Sure. Hi, everyone. Good morning. Oh, I love that. Thank you. We're actually letting people from Overflow come on in now because we have a lot of empty seats in the front. Come on in, sit in the front. I promise we won't call on you. I sound funny. Hi, AV person. Apparently I do sound funny. How about now? Maybe I'm just funny sounding, which could be. I sounded better before. Wow. Okay, how about now? Is now better? Fantastic. We sort of sound checked and everything. How about that? Oh, that's better. Really? You don't? Yeah. I don't, but they have them in the back. There is a little bit of a funny, fuzzy. How about now? So I'm just talking too closely. I'm a close talker. Okay, come on in. Plenty of seats in the front. Come on down. Is it better? It's really not better. But then I cannot read any of my notes. And that would be a problem. How about that? Well, we'll try that for a little bit. I'm not going to talk for very long. It's okay. I'm Toby Burko. I'm the executive director. Oh, you guys are so sweet. Thank you. You do not need to clap for me. I'm going to be here all day long. You're going to be really tired of me by the end. And I'm so happy to see so many familiar faces of people who have come year after year to this conference. I see people who come to the Irvine conference. I am so excited to announce that we are adding a third patient conference this year out in Loma Linda at Loma Linda Medical Center in March. And you'll be getting more information on that shortly. That's just so huge that we were able to secure funding this year to expand this program, this really important program. In the back, I want to introduce some people. Adam Selkowitz is there with his lovely child, Lucy. He is the chairman of our board. The Lupus LA team is also here. Phil, raise your hand. That's Phil. Catherine is in the back. She organized the whole thing. And Ruth is also outside helping. If you have translation, I don't even know if you can understand what I'm saying. If you have translation equipment, apparently it's not working. So we're working on it, and I will come up and make more announcements. Or is it working? It's not working. Okay, we're working on it. Oh yeah, it's working? It is working. Oh, muy bien. Okay, that's the extent of my Spanish. So we have an amazing presentation for you today with some extraordinary speakers to talk about all sorts of stuff. So you're in for a real treat. And also, how many of you liked the later start? If you've been to one of these before, raise your hand if you prefer the later start. Oh, great. How many of you prefer the earlier start? Oh, that's about half and half. Let's see at the end of the day when you write in your evaluation, we'll take that into consideration. Well, we'll try. So I'm just going to give a little information about Lupus LA. How many of you are totally new to Lupus LA in this patient conference? Amazing. Thank you so much for being here. I want to hear on your evaluation how you heard about the conference. So please make sure that you write that in at the end. As many of you know, Lupus LA was created to finding the causes of and a cure for lupus while serving patients and their families of Southern California. We really work with three key hubs. The first hub is we fund medical research, which is really vital. I'm sorry, I'm having horrible allergies today. Which is really vital to finding the causes and cure of lupus. We fund research on a local level, we fund research on a national level, and we also fund local rheumatology fellows. We believe that we need more rheumatologists, which is very important. The second hub, which I know a lot of you are aware of because you're sitting in this room, is patient services. We run a slew of patient programs. We run patient education programs like this one. We also run patient education through Facebook chats, which is a new addition to our program, and we'll talk more about it later. We do one-on-one consultations, healthcare navigation. We do patient-doctor referrals. We do emergency grants of up to $500 once a year for lupus-related expenses. We send kids to camp. We have 9 adult support groups, which I hope a lot of you are part of. And if you're not part of it, you should be. And if you don't live near one of them, we should talk about it. And we also help fund a pediatric rheumatology program in conjunction with Children's Hospital, Los Angeles. We do a lot. And again, Catherine McMahon, who's standing in the back, wave, Catherine, please, thank you. She's responsible for all of that. So thank you. Our third hub is awareness and advocacy. And we always put part of advocacy as part of our program in our patient conferences, so we'll talk more about that later. But through advocacy, we advocate on a local, state, and national level for better access to health care, research dollars, and many other things, and certainly increased government support for lupus. In addition, we also teach patients about advocating for themselves, which again is part of the program today, and we'll talk more about that later. The last thing that we do, if that's not enough, I like to say we're small but mighty, is we do awareness, and we do awareness through a bunch of different ways. First and foremost, social media. We harness the power of Hollywood and our celebrity ambassadors to get the word out about lupus, and we also run events. Some of you have been to our events, some of you have volunteered at our events. Again, I see lots of familiar faces, and if you'd like to know more about our events, I'm happy to speak with you at one of the breaks, and we have an info table outside. At the end of the day, we couldn't meet our goals and couldn't do what we do without you, the patients. Thank you so much. I know giving up of a Saturday is a big deal. It's usually a day of rest for a lot of lupus patients, so thank you. I'm so happy you're here. We're going to move on. Before I forget, I want to also thank the generous sponsors of this event. You know, we can't do it without corporate sponsors. We don't like charging a lot of money for people to come to patient-focused events and education programs. So, Aurinia, Mallinckrodt, GSK, Pharma have all helped support today's event, and they're helping to support all of our patient advocacy and patient education initiatives this year. So and there are representatives from most of those companies here, so let's just give them a round of applause. And thank you. In addition, we have a bunch of information tables outside, including information about clinical trials, which I mentioned earlier. If you have been part of a clinical trial, thank you. If you haven't been part of a clinical trial and want to learn more about it, there are people outside who could tell you about it. Clinical trials are really vital to finding out more about lupus and how to treat lupus and how to move forward with lupus research. So think about it. If it's something that you're interested in, again, you can learn more outside. You can learn more on our website, and there's also links to a national clinical trial information site on our website. Okay, a couple of housekeeping notes. I know you've all heard me say no food or drink. No food or drink. Promise is the last time I'm going to say it. In your folders, there are index cards. The way that we try to move the program along is while each presenter is talking, if you have a question, write it down, put your hand up. Someone will come through the aisles and collect them. After a presenter is done speaking, I'll get all the cards. I will help moderate the question and answer, and our speakers will be sitting there. So again, please don't raise your hand. We're not going to call on you. If you have a question, write it down. We will do our best to get through as many questions as possible. So just know that. Now, a lot of you often come to the UCLA conference to see Dr. Wallace. Dr. Wallace had back surgery this week, and he's fine. He's doing well. He actually just went home. Apparently, he's a little cranky. But his wife told me this morning that he's doing okay. And we have someone who works very closely with Dr. Wallace here to present the latest on lupus, keynote address to you. Dr. Scaramangas is here, Dr. Daphne Scaramangas. Dr. Scaramangas is a recent graduate from Cedars-Sinai Rheumatology Fellowship, where she graduated I have to go, with the highest marks and was just awesome and wonderful, and they loved her. She's currently working with Dr. Wallace at Attune Health, so maybe some of you have even seen her, where she said, but she actually sees patients of all kinds of inflammatory disease, so not just lupus. And I'm really pleased to welcome Dr. Scaramangas. Thank you so much. Oh, I totally didn't set you up. Sorry about that. No worries. In my mind, it just, this one? No, this one?
Thank you.
Yeah. All right, off you go.
Cool. Thank you. All right. I'm really happy to be here. Dr. Wallace obviously wishes he could be, but I hope this is going to be informative, and then we'll try to save enough time to answer everyone's questions. All right, so kind of just a brief overview. I'll talk a little bit about the different manifestations of lupus and the different organ systems that can be affected. We'll talk a little bit about the various diagnostic testing that we do when we're trying to make the diagnosis, and also how we follow patients. We'll talk about some of the treatments. A lot of the treatments at this point are off-label, but we'll talk about some of the future directions and some of the trials that are ongoing. So what is lupus? A lot of people in this room probably already know, but unfortunately it's a progressive chronic autoimmune.
Just a little closer to your...
Yeah. Can everyone hear me? Okay. I've never been accused of having a quiet voice, so I can speak up. All right. So it's a progressive chronic autoimmune condition that unfortunately results in inflammation, and as inflammation goes on, can result in damage to various tissues. It's characterized by periods of flares, so increased disease, followed by times of spontaneous remission, and then subsequent relapses. And this can be different for everyone. And lupus really can affect any part of the body. Most commonly, we see the skin, joints, lungs, and kidneys, but it can also involve the heart and nervous system. And Dr. Shapiro will talk to you about the heart a little bit later. So who gets lupus? The predominant population is women. About 85% of patients are women, and we see that with most autoimmune conditions. The peak age of onset is mainly in reproductive years, so generally patients are in their late teens to early 40s, but all age groups can be affected. And we do see some ethnic predominance, so the prevalence is higher in African Americans, Hispanics, Asians. Again, it's much more common in women. And of the patients we diagnose with lupus, about half will go on to develop organ-threatening involvement. And I do apologize, some of the slides are going to be a little bit different, but the majority will be there in your handouts. So you can see here the sex ratio at the age of onset. So at the extremes of age, so at the very young and very old, we see a more female to male equal ratio, whereas when we look at the peak years, we see more females being affected than men. In terms of the various types of lupus, about 10% of people have cutaneous, so only skin disease, which a form of that is called discoid, and I'll show you a picture of that. That can also be a part of systemic lupus. About 70% of lupus is systemic lupus erythematosus, and that gets broken down into about half of people have non-organ threatening disease, and the other half have organ threatening involvement. About 10% have drug-induced lupus, so there's various medications that can precipitate lupus, and many times if we remove that offending agent, the lupus will remit. And then about 10%, the last 10% is what we call overlap syndromes, where people may have features of lupus and also features of things like rheumatoid arthritis or another autoimmune condition. And then there's also an entity called mixed connective tissue disease, which a lot of the manifestations have some lupus predominant features, but also other features. So these criteria, I won't really belabor this, but these are older criteria. We've kind of moved on to a newer set of criteria. But basically how we were trying to classify patients was based on whether they had these classic skin manifestations of lupus, whether they had other systemic things, so were there joints involved, did they have inflammation around the lining of their lungs or the lining of their heart, were there kidneys involved, and then you would also need to have some specific labs that were positive. We're more commonly using these criteria that were put out in the last 5 years called the SLIC criteria, and you see two columns. On the left, you have the clinical things that we look at, and on the right, you have the immunologic or the lab things. And to be classified as having lupus, you need to have more than 4 of these, so at least 1 from each column. And or another option would be if you had kidney involvement and we did a biopsy which showed lupus and you had one of the blood tests, that would be enough. You wouldn't need anything else. I will comment on this is classification, so you need to fulfill these generally to be part of a clinical trial because we're trying to get a nice homogeneous group to be able to kind of study and move forward. So if you don't necessarily meet every single one of these, that doesn't mean necessarily you don't have lupus, but for the most part, most people fulfill this. So some of the common signs and symptoms, rashes are pretty common. They're usually red rashes on the face, and I'll show you a picture of a lupus rash in a little bit. A lot of people are quite sensitive to the sun. You can notice unusual loss of hair. So we all have some hair loss, but this is a little bit more than that. What we call Raynaud's, where we notice finger color changes, which can be brought on by the cold, sometimes even stress or certain medications can bring that on. Swelling or edema, it can be in the legs or sometimes around the eyes, and that can sometimes be a sign that the kidneys aren't functioning properly. Mouth ulcers or even ulcers in the nose, and these can both be painful or not painful. Swollen lymph glands, some people will have fevers, and that may be a first sign, and people try to figure out why they're having a fever. Extreme fatigue, so being very, very tired. Having joint involvement, so it can be joint pain, joint swelling, aching muscles, and this is a very common symptom. And then what we call pleurisy or chest pain when you take a deep breath in, which can signify that there's inflammation around the lining of the lungs. All right, so moving on to some of the mucocutaneous or skin features. This is kind of a list of the things that we can see, but I'll move along to the next slide, which has some pictures. So starting on the top, I guess left, right, you see the kind of classic lupus butterfly rash, or what we call a malar rash. Yeah, no problem. Should I move back?
Yeah, it's also, the sound in here is really wonky. So we are having tremendous problems with the translation equipment. So I'm going to say this in English, and then Nancy's going to say it in Spanish. So if you are having trouble understanding and you need the translation, you can go to the overflow room where you can see everything, and Nancy and her and Anna will translate live and in person. Okay, off you go.
Buenos días. Disculpe, mi nombre es Nancy, soy una de las intérpretes, mi compañera Ana Chávez. Queremos dejarles saber que la maquinaria para traducción no está funcionando en estos momentos, entonces si ustedes sienten que realmente necesitan interpretación, tenemos el otro cuarto donde tenemos las mismas imágenes aparecen en el otro cuarto, pero nosotros podemos interpretarles en persona. Si ustedes desean, podemos irnos al otro cuarto y continuar la presentación desde ahí con interpretación en vivo. levanten la mano si eso es lo que desean para nosotros poder irnos al cuarto con ustedes. ¿Sí? Ok.
Okay. Thank you. Yeah, no problem. All right. So on the top, you see a kind of classic lupus butterfly rash. And that can be brought on by sun or not, and it can last for variable amounts of time. And that doesn't scar, so that goes away without leaving any residual problems with the skin. Below that, you see discoid lupus. So unfortunately, that is a scarring form of lupus. And when we see a lot of redness there, that means that there's active inflammation. And we have different kinds of medicines we can use to treat that. Below that, you see just some ulcerations that can be on the palate or on the buccal mucosa or the cheeks. Moving to the other side, we see just kind of diffuse thinning of hair. So what we call alopecia. Underneath that is something called subacute cutaneous lupus. So this is kind of a very specific kind of rash that can appear kind of on the torso. It can be part of lupus, or it can be precipitated by certain medications. And then underneath, thankfully this is very rare, is something called lupus paniculitis. And it causes inflammation in the fat and leaves kind of these, you see these dimpling and scars. So that can occur on the face, it can occur on the arms, but again is not very common. Regarding, your musculoskeletal system, you can have a lot of joint pain, what we call arthralgia, or arthritis, so more inflammation in the joints. It can affect any joint. You can have inflammation of muscles or myositis. You can also just have muscle aching, and you can have inflammation of your tendons. Over time, if that goes on, you can have damage to the tendons. You can also have deformities. So in the bottom picture there, you see something we call Jacquard's arthritis, where there's been damage to the tendons and inflammation over time that can leave that deformity that we more characteristically think of when we think of rheumatoid arthritis, and we don't think about that as much with lupus. And then you can have osteoporosis or kind of weakening of the bones depending on, both medications and having a lot of inflammation over time. Regarding the heart, I won't get into this because we have an excellent speaker, Dr. Shapiro, who will kind of go into much more detail. What I will say is that lupus patients, unfortunately, are at a greatly increased risk of having coronary heart disease and stroke. So that is something that we keep in mind. Regarding the pulmonary or lung symptoms, so most commonly from this list will be pleurisy or pleuritis, which is inflammation of the lining of the lungs, and that can cause pain when you're taking a deep breath in. But we can also have different parts of the lungs being involved. Thankfully, again, not very common, but can be life-threatening is pulmonary hemorrhage, where there can actually be bleeding in the lungs, and you may be coughing up blood, and we treat that very aggressively. Also can happen is pulmonary embolism or blood clots in the lungs. And then we always try to make sure that we're not missing an infection because, one, there's inflammation going on, and two, a lot of times we're giving medicines that are suppressing the immune system, and we would treat, an infection very differently than active lupus, so we always need to keep that in mind. Regarding neuropsychiatric manifestations, so both the central and peripheral nervous systems can be involved. And this can manifest very broadly from anywhere from things like depression to seizures or headaches. There's a lot of different causes. So one can be inflammation of the blood vessels, or what we call vasculitis. APS stands for antiphospholipid syndrome, and I'll talk very briefly about that in the coming slides, but that's where you have different antibodies that can predispose you to forming blood clots. You can also have, a thickening of the blood or hyperviscosity. And again, we try to be very vigilant about making sure there's not an infection going on. And that may entail doing things like a spinal tap and making sure that it's not a medication that you're taking that could be causing some of these symptoms. Regarding the kidneys, these are very commonly involved with lupus. There's various features that we look for, and generally in patients who've been diagnosed with lupus, we monitor their urine pretty closely and their kidney function. So the kidneys are kind of working to filter things, and when they get inflamed, they can let through things they're not supposed to, like protein. And when that happens, that can manifest as swelling or edema. We also look at the urine to see if there's white blood cells or red blood cells, again, that are really not supposed to be there, to give us an insight that there is inflammation in the kidneys. And then we look at if the renal or the kidney function is actually impaired, which is what a decreased glomerular filtration rate would be. And the consequence of all of these things is that you can also end up having high blood pressure. The bottom picture is just showing you there's different classes of lupus with the kidneys. So we generally require a biopsy to kind of differentiate those. And the reason we need to do that is the treatment is very different depending on what class. So this is kind of the pathology or classes that we look at, and this is broken down into 6 classes. So for example, class 1 is not that common because we don't usually biopsy that, but we wouldn't treat that because it's very, very minimal. Whereas you take the other extreme, or class 6, advanced glomerulosclerosis, there's a lot of scarring that's already happened. So we don't give more medications to suppress the immune system because that would kind of have a higher risk to the patient without having a lot of benefit. When we can't really change scar, we can only change active inflammation. The middle two, class 3 and class 4, are much more common, and that's what we usually use our medications for, like steroids, prednisone, and other medications. So this is just kind of showing that when you look at all the different organs that can be involved, you see the vast majority, about 30%, have nephritis or kidney inflammation, and all the other manifestations are pretty varied. So anywhere from having inflammation of your liver or hepatitis, to having inflammation of your heart muscle, to having seizures. So it's pretty variable as to what organs can be affected. Regarding the blood, this is a very common abnormality with lupus patients. So it can affect all the different cell lines. So it can cause anemia or low red blood cells. That can be due to the body or the immune system kind of attacking the blood cells and destroying them. You can also have low platelets, which are the cells that help us with clotting. So that can be a predominant feature. You can also have low white blood cell counts, and those are the cells that help us fight infection. And you can have all of these at once, or it can be variable over time. It doesn't have to happen all together. And again, we always consider what other causes could it be. Is it really lupus, or could it be a medication that you're taking? Could it be that you're having blood loss from heavy periods, or could there be an infection? So again, we have to consider all of these things because they're all treated a little bit differently. So kind of moving away from the different manifestations and focusing more on diagnosis. So really there's not one test that can tell you whether you have lupus or don't have lupus. So we kind of look at it by doing several different blood tests, and of course also the history and physical examination. So some of the tests that we do are an ANA test, or an anti-nuclear antibody. There's different other antibodies that are a little bit more specific for lupus. So you may have heard of a double-stranded DNA, or a Smith, an RNP, and then SSA and SSB. Then the antiphospholipid antibodies that I mentioned. And all of these are kind of included in that criteria that I showed you. Then depending if there's rashes, especially if we're not sure what they are, we'll get a skin biopsy. And that can kind of suggest whether it could be attributable to lupus or not. We generally don't biopsy kind of that classic butterfly rash. So these are more rashes kind of on the body, especially when we're not sure. And then if there's any suggestion that the kidneys are involved, we'll do a kidney biopsy. The picture here is just showing you the different patterns. So you may have seen, if you see a lab report, it'll tell you your ANA test. It'll give a number. So it'll say, 1 to 80 or 1 to 160. And then it'll also give you a pattern. So this is just showing you what that means. So it can be a peripheral pattern, diffuse. We don't always put a lot of weight or value in that, but we do look at it, and it is part of the ANA report. So About ANA testing, there's a lot of false positives. So up to 20% of healthy people can have a very low positive ANA. So we do put some weight in how high of a value. So we start calling an ANA test positive when it's 1 to 40 and above. And it's a test where they're kind of doing serial dilution, so it keeps doubling from there. So having a positive ANA though, so one, it can be in healthy people, but it also can be positive with other autoimmune conditions that are not lupus. So things like rheumatoid arthritis, you can have a positive ANA test. Certain infections can cause a positive ANA test. And then there's medications that can cause a positive ANA even without causing lupus. So just having a positive ANA, though generally necessary to have lupus, does not confirm the diagnosis. So NHANES is a survey that gets put out, and they looked at almost 5,000 individuals, and they found that almost 14% of people that were above age 12 had a positive ANA test. And this was seen to be higher among African Americans, women, and as we age, we have a higher prevalence of having a positive ANA. So in the US, I think we have around 330 million people, somewhere in there. 32 million people have positive ANAs, but around, let's say, 1 million have lupus. And of that, 98% with lupus, though, do have a positive ANA test. So I see a lot more people that have positive ANA tests and don't necessarily have lupus. I kind of already mentioned some of these more specific antibodies. So double-stranded DNA can be positive in up to 60% of lupus. And what's good about that particular test is that it can correlate with disease activity. So whereas an ANA test doesn't really tell you, other than you may have lupus, it doesn't really fluctuate when your disease may be more active. But this antibody does. And it can help us to kind of figure things out, especially with kidney disease. It's elevated. So we do use that as a monitoring tool. And then anti-Smith is another antibody that can be seen in about a quarter of lupus patients. So I've mentioned these a few times. So antiphospholipid antibodies, they're part of the lupus criteria. And they're basically these different antibodies. So anticardiolipin is one of them, lupus anticoagulant, and anti-beta-2 glycoprotein. That's what we generally check. About a third of people who have lupus have these antibodies. But of those, only a third have this antiphospholipid antibody syndrome. And what that means is they have these antibodies and they've also either had blood clots in the legs or lungs, and they've had recurrent miscarriages. It's usually pregnancy loss. So how we kind of follow disease progression and activity of lupus is we do routine blood testing. So we follow blood counts, looking at those different cell lines that we talked about. We look at kidney and liver function. We look at markers of inflammation. So there's two that we generally check, something called an ESR and a CRP, or a C-reactive protein. We follow complement levels. So these can sometimes be low when there's a lot of lupus disease going on. But there are people who have these low that are low all the time and doesn't necessarily correlate. So we do kind of have to figure that out. We very frequently will test urine to make sure that there isn't any evidence that the kidneys are being inflamed. And then depending if we're considering things like neuropsychiatric lupus, we may need to do more invasive tests like spinal taps, do other brain imaging in those scenarios. And then lastly, depending on, joint involvement or what particular organs we're monitoring, we may need to do further x-rays or other imaging tests like CAT scans, depending. So this is an image that comes from Dr. Wallace and Dr. Beverhan's textbook on lupus, and just kind of shows you the different skew of the clinical and lab manifestations. So you can see at the top, what they report is 97% of people have a positive ANA, so almost everyone. And then from there, the overwhelming majority have arthritis or joint involvement, and skin is also very common. And from there, it starts declining. So all the other things that we've kind of discussed are variable and less common, but do occur. So this sorry has a lot of words on this slide, but in terms of the other things we're thinking of, so when we're seeing people with some of these complaints and we're trying to put it together, our differential can include other autoimmune conditions very commonly. So not just lupus, but we're thinking of things like rheumatoid arthritis. Could it be myositis, so inflammation of muscles, or vasculitis, inflammation of blood vessels, things like Sjogren's, which I'll talk about next, or undifferentiated connective tissue disease, which sometimes people are told they have before we make the diagnosis of lupus, because they just don't have enough things yet, but they may in the future. We also consider infections, certain cancers, especially lymphomas, can sometimes be mimickers, other neurologic conditions like multiple sclerosis. So the list is quite long. This is kind of simplifying what we're thinking about. I wanted to mention Sjogren's because it can either be an autoimmune condition on its own, or it can be part of other autoimmune syndromes. And about 20% of patients with lupus also have Sjogren's, so that's pretty common. It's usually characterized by having dry eyes, dry mouth, and some joint complaints like arthritis. And it's much more common, so about 4 million people are thought to have Sjogren's in the US, and the vast majority, again, are women, 90%. And of these, 70% have these antibodies, what we call SSA or SSV, and a lot of lupus patients do have these antibodies. And what we kind of monitor, the picture is kind of showing you, Sjogren's like lupus can affect all sorts of organ systems, but the vast majority of involvement is with the salivary glands, hence the dry eyes and dry mouth. But a lot of patients can unfortunately develop lymphoma over the years, so we keep kind of a close eye and a vigilant eye to see that that doesn't occur. I also just wanted to comment on undifferentiated connective tissue disease because we do sometimes use this as a diagnosis when, like I said, people haven't met everything to be called lupus. So I won't get into the details, but to say that generally people will have a positive ANA test, and then they may have things like finger color changes or arthritis or maybe oral ulcers, but don't meet all the other criteria or don't have, the more specific antibodies. And of these people, about a third kind of will go on to develop something more defined like lupus. The rest, a third will kind of stay in this category, and then a third will kind of resolve their symptoms on their own. I'll also just mention fibromyalgia. So this again can be seen on its own or it can be part of lupus. And some of the characteristic things are having a lot of stiffness in the morning, being tender in these kind of specific areas, having chronic non-restorative sleep, and generally, especially if it's occurring on its own, we don't see any inflammation on the physical exam, so we won't see any swelling in any of the joints. The major organs are not affected, and when we test blood tests, they're generally normal. And this is a diagnosis of exclusion, so we have to rule out other things before we kind of arrive. So kind of moving on to talking about some of the causes of death, unfortunately, in lupus. Historically, there really was active disease was what people were dying from, complications from having inflammation in the kidneys, and then infections was very common. And as we move forward now, that still kind of seems to be the most common causes. So active disease plays a role generally only in the first 2 years after diagnosis. Infections are still common. And then the kind of newer thing that we've learned is complications that are associated with having heart disease. And we see this more after about 10 years of having had the condition. So this was, again, kind of the same thing, showing they followed people with lupus, almost 10,000 over 40 years, and 1,200 deaths occurred. And what they found was, even though things were getting better, the death rates were still much higher for common causes of death than we see in the general population. So it was 8 times higher for kidney causes or renal causes, 5 times higher for infections, and again, the heart disease piece that I've mentioned a few times was 2 times more common. And so even though we've seen that there is an improvement in survival, lupus is still unfortunately a chronic disease, and the mortality rates are still higher than the general population. So this comes from Rochester, Minnesota, where they have really good epidemiological studies, and they found that even though the survival rates have really improved compared to the 80s and 90s, the survival is still worse than the general population. Again, kind of mentioning the heart, kind of as a setup for Dr. Shapira's talk, but the risk of MI or heart attack is more than 50 times greater for women. And this increases with increasing age, and that may be a reflection of longer disease duration. So you can see the yellow bars are, or the orange bars, sorry, are lupus patients, and the blue is the general population with age, increasing age down at the bottom. And as age increases, we see more of that. In addition, progression to kidney disease, to end-stage kidney disease or ESRD, so requiring dialysis, hasn't really decreased all that much, unfortunately, over time. And this seems to vary. So people who have a lower socioeconomic status, unfortunately, have worse outcomes, as do certain ethnicities, such as African Americans. 1/3 of lupus patients, so over time, within 5 years, will accrue some form of organ damage. So again, this is showing you at the bottom people who've had disease for 1 year versus at the very extreme 25 years. And you see as the disease goes on, even with treatment, we are accruing some damage, unfortunately, to the organs. Another piece is that work loss, again, is a common consequence. So this was a study not that long ago where they followed patients with lupus and found that about 1/3 of them had to stop working within 4 years of their diagnosis and follow-up. And some of that was associated, so about 1/3 they found this was because of musculoskeletal problems like arthritis or muscle issues. 38% had neuropsychiatric forms of lupus, which precluded them from being able to work. And then some patients had thrombotic or kind of blood clots. So in terms of the challenges that we face as we're trying to manage lupus, so one of the things is kind of coming up with a timely, so a prompt diagnosis, so we're catching people before we've accrued all this damage, and allowing for a correct diagnosis to be able to treat appropriately. We want to treat inflammation to be able to avoid the damage from happening, but we want to do that to the best of our abilities without causing harm. And that can be a problem because some of the medications we use, and I'll get into the medications in the coming slides, things like steroids that really do work and are great anti-inflammatory medicines, unfortunately can have a lot of consequences to their use. We want to, again, address and screen for other comorbid or other conditions, and I'll talk about that again in the coming slides. And then forums such as this, so it's very important to establish social support and kind of outreach for patients so they don't feel alone while they're managing their lupus. So some of the kind of things that we think about when we're trying to manage lupus are thinking of the physical measures, then we'll talk about the medications, and then the different modalities such as counseling. So regarding physical measures, so we know that UV light triggers lupus disease activity, so wearing sunscreen is very important and trying to avoid the sun. Things like physical therapy and occupational therapy can be really important to kind of keep up mobility. Things like vocational rehab, we want to try having people keep working. So, getting things like ergonomic workstations or having people be managed in those settings also. Exercise and diet, I'll have a few slides on the importance of that. And then managing fatigue, which can be very difficult. So there was a study, this was done some time ago, but basically looking at using exercise, different types of exercise programs. And what they found was they took almost 100 patients with lupus and split them up into either doing a graded exercise program, a program of relaxation, or just the usual care that we generally do. And what they found was the people in the exercise group did much better compared to the people who were just in the relaxation group or in the usual care group. And when they did their statistics, they found that this was a significant difference. In terms of diets, there are some different things out there. So there's been a few studies looking at two specific diets in lupus. One is something called a low glycemic index diet, and the other one is looking at calorie restriction. And what they found was looking at both of these diets in patients with lupus, they did have a decrease in their fatigue compared to their baseline. There has also been studies looking at using fatty acids, like omega-3 fatty acid, and this has also been shown to decrease lupus disease activity. And I think there's also some ongoing studies looking at that currently. In terms of further kind of proactive and preventative strategies, so patient education programs such as this, working on eliminating non-adherence. So a lot of times we'll prescribe certain therapies and they, for whatever reason, are not taken. So I think a big piece of that is education. So explaining why we're giving a particular medicine, because a lot of the medicines sound really scary. So we need to make sure that we're kind of explaining why we're doing what we're doing. Having access to specialists. So rheumatologists, they've done some studies and it shows that our workforce is kind of declining and the need for rheumatologists is great. And at least in LA, we do have access, but there's certain other parts in the country where there really is not a lot of rheumatologists, and especially access to pediatric rheumatologists is low. Kind of the same thing about doing exercise, physical therapy, and then monitoring for these other conditions. So things like high blood pressure, high blood sugar, especially for using steroids. We want to be careful because they can cause diabetes, cause thinning of the bones. So we want to monitor bone density tests, look at cholesterol, if someone's smoking, do what we can to kind of help them to quit. And then other things like heart screening, stress tests, or duplex scanning, which is looking for blood clots as needed. In patients who do have fevers, we want to be vigilant about making sure, is this because the lupus is active or is it because there's an infection that we need to treat? And then checking for these antibodies. So, medications really unfortunately don't work in people who aren't taking them. And lots of studies have showed that, I know, it's a novel idea, but it really doesn't work if you're not taking the drug. So a lot of people start, they say, when the nurse goes in and asks them, they check the list, they say they're taking it, and then when you kind of ask deeper, a lot of people aren't taking the medicines. So they've done various studies on this. A lot of patients don't go through with, either the medicine itself because they're scared of side effects, or they try it and they do have a side effect and they're concerned and don't kind of reach out. With some of the medicines, we do have ways we can make it more tolerable. So kind of having that interaction so we can work on that if needed. So some of the medicines that we use to manage lupus, and some of these may be familiar to some of you. So topical things when it's skin disease. So we'll use topical steroids, and a lot of times a dermatologist helps us with that. NSAIDs, or anti-inflammatories, so things like ibuprofen, Aleve, meloxicam. Those can be used for a lot of different parts of lupus. So joint complaints, they can be useful. For pleurisy, they can be useful, so inflammation of the lungs. Antimalarials, kind of one of our mainstay and first-line drugs, and I'll have a slide on that. Then steroids, a lot of people's friend and foe at the same time. A lot of other immunosuppressive agents, which I'll kind of list here. So nitrogen mustard, Dr. Wallace will tell you he's used that a few times back in the day when there wasn't a lot of other things to use for active kidney disease. We don't really use that anymore, but you do use medicines like Cytoxan or Cellcept. And I won't get into the details of all these, except to say we kind of pick the medicine based on what organ is involved, what organ is affected. So it's not the same thing for everyone. So if you come and your big issue is kidney inflammation, then we may use Cellcept. But if your big issue is arthritis, Cellcept doesn't work as well, so I'll use methotrexate. So we kind of have to tailor it to the person. In terms of antimalarials, so the medicines are Plaquenil or hydroxychloroquine. And then there's something called quinacrine and chloroquine. So these take some time, but most patients with lupus will be on this medicine. They take about 6 to 12 weeks before we start seeing the inflammation benefit and the sun protection effect. And the vast majority of people, about 80%, do respond, and this medicine is really good for non-organ threatening lupus and for skin manifestations. We have found that it decreases the rate of flares and the risk for having other organs involved. And it has all these other consequences which are good. So it can help with blood sugar, with platelets, so the blood clotting cells, and also lower cholesterol. So it has a lot of good benefit. And it's safe, so we can use it in pregnancy. It's safe to breastfeed. And lastly, there really isn't much downside to the medicine. There's not a lot of toxicity. I won't talk about eyes at all because we'll have a talk about that later. But other than that, it's very safe. So steroids, we use them a lot, unfortunately. They work really quickly, and they're very potent anti-inflammatories. So they suppress a lot of the immune response. And when we use them chronically, unfortunately, people are at an increased risk for a lot of different things, infections being one, osteoporosis, cataracts. So again, it's kind of a risk-benefit, and every case is different. There's different steroids that we use. Prednisone is probably the most common, but depending on what we're trying to treat, so let's say it's a pregnant patient and we need to get the steroid to the fetus, we may use a different steroid like betamethasone. And then how we administer that is different. So sometimes we'll prescribe it once a day or multiple times a day. And other times, especially if there's active kidney disease, we'll use pulse dosing or big doses through an IV rather than orally. So again, I won't get into all of these, but depending kind of what organs are involved, so if you have skin disease or if you have, Raynaud's, we'll use different medicines in addition to the other medicines that I've showed you for lupus. Belimumab or Benlysta, so this was kind of exciting. It was the first drug approved for lupus since the 50s. It was approved in 2011, and it carries an indication to treat patients, adult patients who have active lupus with positive antibodies who are receiving standard therapy. It's the only biologic drug that we have approved for lupus, whereas for conditions like rheumatoid arthritis, we have a lot of biologic therapies that we're using. And in the last few months, there's a subcutaneous form of the medicine that's been approved that patients can inject on their own at home. So of all the medicines I told you about, the vast majority are kind of off-label. They don't really carry the designation or aren't approved for lupus. And Benlysta was the first drug approved in 50 years, and we haven't had another approval since 2011. So clearly we do need new medications for lupus. And as I've shown you, unfortunately, lupus still has a really high morbidity and mortality rate even in the year 2017. So we've gotten better, but we still have room for improvement. So kind of showing you the drugs that rheumatologists were using in the 60s. They were using things like steroids, methotrexate, and cyclophosphamide. That's kind of what we're still using now. So we still have some room for improvement. So with that in mind, the FDA put out this advisory in 2010 to kind of help people in moving forward how to be able to advance lupus research and lupus treatments. So they kind of put this out to say, well, some of it's self-explanatory, that we should have well-controlled trials, that the trials should be good, that they should be at least 1 year, and that the people that we're putting into the trials should really have lupus, because it'll be hard to show that we're making a benefit if the patient doesn't really have lupus. And that we should maybe break up patients into patients who are more severe and less severe, because it may be hard to show differences if we're putting everyone together and trying to show an outcome, and we've had trouble doing that. And making sure that we have really good definitions. So it's hard, as I've shown you, lupus can affect so many different organs, so many different people in different ways, and that can be hard to kind of quantify. So we need better markers and measures to be able to follow that over time, and that's also been challenging. And then this last piece are patient-reported outcomes. So that's become more important that we include what patients are reporting in studies. So there's been a push to include that. So since 2005, more than 20 lupus drugs have failed in clinical trials. So you see this long list. And we know that a lot of these medicines do work. because we do use them, but unfortunately they did not meet what they were trying to prove in the studies, so they weren't able to be approved by the FDA, or they didn't move forward in their development. So the positive results from all of these is belimumab or Benlysta, which I just showed you, and this other medicine, which anifrolumab, which is not approved right now for lupus. So it sounds kind of dismal, but we have all these therapies and all these targets that we know can potentially help lupus disease activity. So again, I'm not going to get into all of this, but there is a lot of ongoing research trying to look at these different areas and seeing if we selectively target certain things, can we come up with new medications. So kind of the reasoning, so a lot of really smart people that are experts in lupus have gotten together to try and figure out why do we keep testing all these medications and why do they keep failing. So in some it really was that the medicine didn't work, or it did work but it's just not safe, and that's not an acceptable level of risk. In some of them, the way the designs of the trials was flawed, so it was very difficult to show differences. And we use something in clinical trials called primary outcome measures, so that's what we're trying to prove. And sometimes, unfortunately, the right measures have not been chosen, making it very difficult, again, to show a difference. The trials sometimes just aren't enforced properly, or we see differences between a trial that's run in the US versus a trial run in a different country. Sometimes because they force patients, so you're doing okay and you're taking a certain medication and the study says, well, you must stop this medicine. And that can then be challenging to kind of recover from. Or steroids work really well, so sometimes it can be hard to show a difference when we're using a lot of steroids or making people, increase their steroids during the trial. Like I mentioned, and Dr. Wallace will say, we're not that great at measuring lupus, unfortunately, and we really do need better biomarkers. And there is a lot of ongoing research trying to find something either in the urine or blood or something that we can monitor. So even though through all this, and it sounds very pessimistic, there's still a lot of hope. So kind of the major unmet needs are patients who have active lupus that's non-organ threatening, but they're still having a lot of disease activity, even with medicines like the antimalarials. So we end up using medicines like steroids, which have a lot of issues that I've told you about. Again, we're kind of trying to find this biomarker, especially for kidney disease or for neuropsychiatric lupus. And then pediatric lupus is also another unmet area. So there's a lot of different networks. This one, LUCIN, or Lupus Clinical Investigators Network, is providing, investigators, research, patient support, and free access to data to any investigators that want to access that to try and kind of promote research moving forward. And then to conclude, some of the lessons we've learned. So really the most efficient method for advancing lupus through trials is to find drugs that may work and use them in highly enriched populations. So selecting the right people for the trial and preferably doing them at academic centers that are kind of well-versed in doing this. We need new metrics in lupus, and that's actively being worked on. And then we need to be considering both prevention, induction, and keeping flares at bay. And there are a lot of very promising medications currently being studied in clinical trials. And there's also a push to repurpose medications that are approved for other diseases already, so not starting from scratch, and seeing if we can repurpose those and use them in lupus. So with that, I will conclude. Thank you for listening.
Sounds good. So if you have questions, I do not see my handy question grabbers. Hold on that thought for a second.
I can grab them too.
That's okay. Catherine, can you hear me? Catherine? Hi, we need question grabbers. So they will. And I'm also going to invite up Dr. Jay Shapira. Dr. Shapira, there you are. I feel like I'm playing Let's Make a Deal a little bit. Come on down. You are the next contestant. That's The Price is Right. So we thought we'd do something a little bit different today, which is have both doctors up here for both question and answer sessions. Both Dr. Scaramangas and Dr. Shapiro will be up here for questions now until we're out of time, and then Dr. Shapiro is going to present, and then they're both going to come up again. So if your question isn't answered this time around, maybe it will be answered next time around. I'm going to come over here and do that. Thank you. Awesome. Yes, I don't know how to do that. How do I turn off the projector? Can we turn off the projector temporarily?
Here's the thing.
Is it on here?
Should be able to do it on here. It didn't work.
Do you have to do it to there?
Here. I'll do it on here.
Oh, projector. No, wait.
This one?
Yeah, it's not
Does it
working.
work?
Okay. These are in no particular order because I haven't sorted them yet. I was told that lupus doesn't... Okay, it's off now. That's good. Okay, thank you so much. I was told that lupus doesn't affect the joints of the spine. Is that true? My spine is what hurts the most in the morning.
So that is true for the most part. Can you guys hear me okay now? No.
Oh, maybe those aren't on.
Yeah. Talk right into it. Now? Okay, there we go. For the most part, lupus does not really cause arthritis or inflammation in the spine. But I will say when you have a lot of inflammation and you're not feeling well, you can feel stiff and generally achy in the morning. Sometimes we do try to figure out if there's fibromyalgia also kind of concurrently on the picture, and that may be treated a little bit differently. But for the most part, that is true. Lupus does not cause inflammation in your spine.
Okay. Is high blood pressure an indication of pleuritis?
Say that again?
That's what it says. I think it's going to say, that's what it says, but I think they're talking about pleurisy.
Oh, okay.
That's kind of what it is.
Is high blood pressure an indication of pleuritis? No, simply. High blood pressure is certainly common in lupus for a variety of reasons that Daphne touched on. Certainly pleuritis is an indication of pleural involvement or pericardial involvement because of inflammation of the pericardium. And I'm going to show you guys some gross pictures after lunch and explain more of what that is.
Okay. Have there been any specific dietary changes that have shown heavily to impact lupus system? There were 2 diets mentioned during the slide, the low glycemic diet and the other one. Could you please talk about these? And actually, there are quite a few questions about dietary restrictions or changes, so if you could give a general answer, that would be great.
So I think those 2 diets that I mentioned are what there's been formal studies conducted in. For example, in our office, we have a holistic nutritionist who kind of works on anti-inflammatory diets, working on elimination. So we don't have a lot of strong scientific data, I would say, but I've had a lot of patients have great success by using that as an adjunct to the other therapies that we're also using.
Okay, so I've got a little bit different answer.
Okay.
So you know, the reason we're talking about cardiac today is because, you know, cardiovascular disease is the most common cause of death in lupus, clearly, and it's the first place winner by a mile. So we can talk about diet in terms of if it's that common, and not from the anti-inflammatory point of view necessarily, but because of heart disease. And what's the most common heart disease? It's atherosclerosis. And atherosclerosis is just plain old coronary disease, you know, plaques that are in your coronary arteries that cause heart attacks. And so we feel as though the standard recommendations that cardiologists and Daphne preaches and internists preach, you know, about a low-fat diet, low-cholesterol diet, Mediterranean diets, American Heart Association diet, a low-salt diet, all of these things apply to patients with lupus because the chances are greater than 50% that sometime over the lifetime, if you're lucky enough to be greater than 10 years out, according to your slide, that this will help you. And it will help you even earlier than that, because we know that these plaques start to form subclinically, which means before the onset of symptoms or before the onset of detection at a very young age and before the first 10 years. So in order to prevent that from being a problem later on, we recommend these diets on an early basis. And as soon as you are diagnosed, you should look into this type of a dietary program. And of course, you know, the science behind, you know, cholesterol theory causing heart disease is fairly sound. Yeah.
Thank you. How soon or long after a patient is diagnosed with lupus does a patient get diagnosed commonly with a heart condition? So basically, what's the connection between lupus and the heart? But I think, Dr. Shapiro, you're going to talk about that later.
I can give one sentence right now. It's a big preview. They're both inflammatory diseases.
Oh. Also, I want to say these are excellent questions, so thank you so much. Keep them coming. Have we progressed in any area of stem cell therapy for lupus?
So I'll say I'm not very well versed in that aspect, and everything at this point is really experimental, so I don't think we have anything at this point.
Okay. Again, these are in no particular order. How does lupus affect menstrual cycles?
So one thing, just kind of going in terms of hormonal therapy. So lupus affects, obviously, as we've talked about, majority of women. So we've tried looking at various hormones to see is that something that's triggering disease. That hasn't necessarily been worked out. People do find that during their menstrual cycle, likely related to hormonal changes, they have more aching, more inflammation or activity of the disease. So that's where anti-inflammatories like ibuprofen, Aleve can be helpful around menstrual cycle time.
What is the range for anti-DNA and how high can it go?
So there's a few different assays that we use to test double-stranded DNA. So the different numbers really depend on the lab. So I've seen it go up into the thousands, and that's very rare. And again, it's more of a trend. So we're using it, if your double-stranded DNA is 2,000, and I'm seeing you today, I'm going to see you back in a few weeks, I'm going to treat you with something, and then I'm going to repeat that test and see that it's coming down. So I use it as a marker.
Thank you. For lupus-related mental health symptoms, such as psychosis, does treatment differ for non-lupus-related mental health issues? Are psychiatrists generally aware of these connections?
So mental health conditions that affect the general population can also affect lupus. But what's important is if we believe that active lupus, so it's actually CNS lupus, so the psychosis is related to active lupus and active inflammation, that would be treated with medications to suppress the immune system. And we're generally very aggressive if that's the case. Whereas if we're talking about things like depression or other conditions, that's where we do use psychiatrists, and you may not necessarily be using immunosuppressive agents to treat the disease.
Can you talk about long-term side effects of using Plaquenil for more than 10 years? 10 years or more?
So I don't want to steal the thunder of the eye talk that we're going to be having, but after 10 years, so kind of the data that I'm aware of is around 5 years, the potential incidence of eye toxicity is less than 1%. And once we get to 10 years and greater, that's when we start seeing more eye toxicity. So that's when we're very, diligent about doing very regular eye examinations. And I will say that if we are using the appropriate dose, so generally we're using 5 milligrams per kilogram, it is safer and we get more longevity out of the medicine. And then lastly, quinacrine, which is another antimalarial agent, which needs to be compounded, doesn't have any eye toxicity.
Is the disease, okay, hold on. All right. If the disease is in remission, is it okay to stop taking my medicine? I'm just going to say we always get one or two of these questions, and I love them. So let's see what the doctor says.
So because this is kind of a condition where we have periods of remission and then periods of flares. So that kind of needs to be a shared decision. So for me, it depends on what organ systems have been affected in the past. So if you've had really severe organ-threatening disease, even though you may be in remission now, it's hard to predict. We may keep a really close eye on things and decide to taper medicine, so start taking them away. But in those cases, it's hard to stop all medicine. And someone who may have, non-organ threatening disease, so maybe it's been more skin and joint, we may be able to kind of come down on, for example, if it's Plaquenil and see how things are going, do every other day, and then maybe take it away. But that's very individualized, so it's hard to say for sure.
So this is for Dr. Shapira. There's lots of, I'm going to try to break this down. Basically, this is a lupus patient who's been a lupus patient for more than 30 years and has had 2 open heart surgeries due to aortic stenosis. Can lupus damage the aortic valve or I think that, yeah.
We're good at reading bad handwriting if you want some help.
Yeah, actually, that's right. You guys should be. I can't make out something result.
Or genetic results, yeah. Yeah, good, okay, thanks. The first question is, yes, lupus can affect the aortic valve. Mitral valve is most common. Aortic valve is less common. You had your first open heart surgery, is an anonymous question, many years ago. And in the original valve that was excised, taken out in your original surgery, there would have been a pathology done. A pathologist examined with a microscope and grossly the aortic leaflets that were removed. And you could find out if it was rheumatic or if it was due to lupus or another cause, or a bicuspid valve, which is a congenital malformation. So it's a very good question, actually. And if you can go back and find the pathology from your original surgery, you can answer this question precisely.
Thank you. How long can one stay on a low dose of prednisone treatment, like a 5 to 10 milligram maintenance, and are there any bone density consequences?
So I guess you can stay on it technically indefinitely. Ideally, we try to come up with other medications to be able to spare using steroids chronically. We consider anything above 7.5 milligrams for 3 months as a high dose of prednisone. And a lot of those cases, there are guidelines suggesting that we should be protecting the bones when we're using that dose for that duration. So we'll generally get a bone density, and a lot of times we'll treat for osteoporosis, even if it's not there, as a preventative strategy. The caveat to that is a lot of people are of reproductive years, so some of the medicines that we use for osteoporosis, we just have to be careful because they can't be used during pregnancy, so that's something we consider.
So we have a bunch of different questions that really ask about the relationship with gut and gastrointestinal issues, such as celiac or other immune disorders of the stomach and lupus. Can you talk about that?
So we know that autoimmune conditions can commonly occur together. So it's very common to see patients who have Hashimoto's thyroiditis with celiac, with lupus. So a lot of our patients are also followed very closely with a gastroenterologist, so depending on what that condition may be. Some people do have issues with motility, and SIBO, or small intestinal bacterial overgrowth, is very common. So sometimes antibiotics need to be used. Some of our medicines, unfortunately, can have gastrointestinal side effects. So Cellcept or mycophenolate, which we commonly use, can cause GI side effects. And then lastly, there's a lot of research kind of ongoing at this point to look at the microbiome and see if we can either use that as a target or use that as insight into kind of what's going on, because there's this kind of gut joint connection. So there are other autoimmune conditions like spondyloarthritis, which is inflammation in the spine, and that seems to have a link between the gut and joints. So that's all kind of actively being researched, but we don't have a lot of information at this point.
How does one combat cognitive impairment or lupus fog?
So lupus fog is very common. It's also common with Sjogren's, and it can be common with fibromyalgia. We don't have great medicines to help with that. Cognitive behavioral therapy can be helpful. There's been some suggestion of DHEA, which can be used both for fatigue and for fog. Quinacrine, I found, if patients have a lot of fatigue, can be used. But unfortunately, I don't have one medicine or one thing to suggest that takes away all brain fog.
There are a couple of questions about whether or not lupus is genetic, and actually more specifically, should your children, if you have lupus, should your children be tested for lupus?
So we do know that there are certain genes that seem to predispose. The kind of basis for a lot of autoimmune conditions is that in the right host, so someone who has this genetic background, that there's a second hit, sometimes a virus or something that kind of tips it off into disease. Because even in patients who are, twins, one may develop lupus and the other may not, even though they have the same makeup. In terms of, the likelihood of passing on lupus, we get asked that a lot. So you can have neonatal lupus. So a patient with lupus who gets pregnant can pass lupus on to the baby. Generally, it's a rash that's self-limiting and goes away. I think it's about 5% of patients who have lupus, their child may also have lupus, so it's not that high, but it can happen. In terms of doing specific testing, not necessarily unless there are symptoms, because just testing an ANA test, it may be positive, and we do find that the ANA test can be positive in families. And there's also some research ongoing both with rheumatoid arthritis and lupus to say if you have these antibodies, we know that the antibodies are present for many years before the disease becomes apparent. Is there something we can do to prevent disease? So they're looking at using even medications like Plaquenil or other drugs to see if we follow people over time and we treat them before they develop anything, can we have any impact on that?
Thank you. I've been on Benlysta for 3 years. What are some of the negative side effects, outcomes I should be aware of? Will I have to be on Benlysta forever?
So in terms of being on it forever, it again depends on kind of the disease course. Sometimes we'll try and taper medications. We don't have a lot of good data on what to do, but if people are doing well, we sometimes try to decrease medication over time. In terms of the long-term side effects, Benlysta is pretty safe, and as far as a biologic drug goes, there isn't as high of a risk of infection and such as we see with some of the biologic drugs we use in rheumatoid arthritis, but that certainly can happen, so that's something we monitor for. But in terms of very specific long-term complications, is there anything?
Yeah, Benlysta is one of the really heart-friendly medications. I mean, if you look at the whole list, Benlysta is kind of the winner there.
Can you please discuss lupus and high gamma globulin protein levels and polyclonal bands?
So there's a test that we do called a serum protein electrophoresis. It just looks at different proteins. And with lupus and autoimmune conditions, we can see something called a polyclonal gammopathy, meaning there's different types of cells. And we monitor that. It can also be seen with other conditions, so not only lupus. And other than that, it's something that we sometimes monitor. We see it probably more commonly with Sjogren's than we do with lupus, a polyclonal gammopathy. And we kind of follow that over time to make sure that it doesn't become monoclonal, meaning all the cells are coming from one cell line, which can be more concerning.
Thank you. Can you, someone has a question about organ involvement, and can that include the thyroid?
So lupus itself not specifically attacking the thyroid, but it can be seen with thyroiditis or Hashimoto's. So you can have, and quite commonly, patients who have lupus also have an autoimmune process that goes on in the thyroid that we call Hashimoto's. And a lot of times that needs thyroid replacement.
Thank you. Can lupus cause arrhythmias or slow heart rate, and can methotrexate cause the speeding to a lower to get lower significantly. Either, yes, heart rate, sure. You guys just want to field the questions? I'll just hand them to you. Sure. All right, here's some more. We have 15 more minutes, and they're going to get through as many as they can, and then they're coming back later, so we'll just keep going.
Yes. So lupus can cause arrhythmias, yes, and there's multiple mechanisms through which lupus can cause arrhythmias of all types. It can be the disease itself causing myocarditis. It can come from pericarditis. It can come from coronary artery disease, both macrovascular, the big vessels, and something we'll talk about, the microvascular. It can come from the medications. Some of the medications are known to cause significant arrhythmias. Either, even the anti-malarials, the hydroxychloroquine, can cause that. So, yes, there are many arrhythmias. Atrial fibrillation is more common. So there's a number of mechanisms by which arrhythmias can happen. And yes, bradycardias can occur with a variety of medications. And these medications, for some patients who already have underlying heart disease, need to be monitored when they're given. And I'm sure Daphne can tell you about some patients that they have to monitor during infusions when they give the medications because they have underlying heart disease. So it's a very good question, and it depends on the patient about how close we have to monitor patients. But you can have all kinds of arrhythmias, including PACs, atrial fibrillation, PVCs. You can have heart block, AV conduction defects, a number of different things. Take the easy ones. Huh?
Okay. Filtering them through. So the question is, do the calcium channel blockers used for Raynaud's help to reduce pain? So calcium channel blockers are a class of blood pressure medicine. They're the first line agent that we use for Raynaud's because they help to dilate or open up the blood vessels and allow more blood flow. So if there's a lot of spasming of those little blood vessels and if there are ulcers that have formed on the digits, then this can certainly help to reduce that. But in terms of reducing, I'm not sure if the question is to reduce finger pain or general pain. Finger pain maybe, but general pain, I would say no.
Okay, I figured that I could read. The question is, I was 40, and I had a heart attack. I exercised all my life, and I still almost died. I assume I'm going to assume with this question that you have lupus. So although it doesn't say it, I'm just make that assumption. The answer is, and Daphne showed a slide, which is such a great slide. I have the same slide in my collection about the incidence in young women between the ages, I think it was 35 and 44 or something like that, is 50 times what it is in the general population of women that age, 50 times. So that as a cardiologist, when we see someone who is 40 years old, a lady who's 40 years old who has a heart attack, that's just a striking occurrence. And we look for lupus almost routinely in that patient. We don't always find it, of course, but we find it fairly frequently. And so it is a major force. We know that there are certain factors in lupus. Those that have antiphospholipid antibody have more heart disease and more problems with thrombus and more problems with blood clots and things like that. And so I think that the exercise that you did helped. I think that if you didn't smoke, that helped. I think if your blood pressure was well controlled, that helped. If you had a good diet, that helped. But lupus as a risk factor is a more potent risk factor than all of the other traditional risk factors combined. And so, unfortunately, even though you did the right thing, lupus overwhelms all the good behavior. Yet, still do the good behavior because you don't want to add to the risk factor you cannot modify, which is the lupus.
So the question is, how do I know I have a fatty liver or a symptom of lupus when my AST and ALT is elevated? And AST and ALT are liver enzymes that we commonly monitor. So conclusively, how we know about fatty liver is we will send for an ultrasound of the abdomen, which will show a fatty liver, essentially. So having elevation in your AST and ALT, that could be a medicine that's causing it. It could be a component of fatty liver, or something called lupus hepatitis. That's pretty uncommon. So it would be more commonly the first two things rather than the lupus itself causing the elevated markers.
Just one for you. It's a cardiac question. Good luck.
Okay. Thank you. I may need to phone a friend. All right. So the question is, which echo tests are recommended? The frequency of echo tests, and who prescribes the echo tests, primary care or rheumatologist. So I generally, it kind of depends. So I do send patients with lupus for echo tests, depending on what I'm looking for. So if I'm thinking they may have pericarditis or inflammation, I may send them for an echo to look for fluid. There are certain antibodies that seem to predispose to things like pulmonary hypertension or having high blood pressure in the lungs, something called an RNP. So in those patients, I send for an echo before I would send to a cardiologist, for example, or a lung doctor. And then if there are a lot of cardiac complaints, I generally send to a cardiologist before I do the echo test. And then depending on what the results show kind of determines how frequently we need to obtain them. If it's something that we need to do regularly, so for monitoring the blood pressure, the pulmonary hypertension, then that's something that we do much more commonly. So you may have a different take on some of that.
No, I think I agree with you, what you said. I would just expand on that a little bit. Because the incidence of valve disease, pericardial disease, and myocarditis, if you accumulate them all, is greater than 50%. I believe that screening on an annual basis for patients with active lupus is a good idea. And screening means an EKG, and it means an echocardiogram. The EKG is to look for arrhythmias and signs of a silent heart attack or ischemia, which means lack of enough blood flow to the heart muscle due to coronary disease. And you want to also watch for signs and symptoms to have one done even sooner if you have pleuritic pain we talked about before. Now, this says what type of echo test, which echo test. So there are two types of echo tests. There's the transthoracic echo, which is the common echo that we do. So it's on your chest, bare skin, and it's a little transducer about the size of my thumb with some coupling gel that's put on the chest. You make an echocardiogram. It's a fancy ultrasound. See the heart. We can evaluate the pericardium, which is the lining of the heart, which is frequently inflamed in lupus. We can evaluate the myocardium, which is the heart muscle, and we can evaluate the valves. Now, the incidence of echo abnormalities in all of those categories, if we were just to take a group of active lupus patients, is probably at onset of lupus, probably around 25%. But over the course of their disease, it goes to greater than 50%. We can pick up early problems which are still subclinical. In other words, we can pick up valvular abnormalities, Liebman-Sachs endocarditis, growths on the valves themselves. We can pick up at an early stage, and that's good to do because we can then begin treatment to prevent strokes and other complications from that. Now, that said, the easy type of echo to do is the transthoracic. Now, there's another type of echo called a transesophageal echo, which we've, I think, is alluded to in this question. And a transesophageal echo gives you twice the yield of a transthoracic echo. Twice the yield means twice the amount of pathology that you can see. Now, it is more trouble to do it. It's not a free increase in yield. And it's done by taking a small probe putting it into the esophagus like an upper GI endoscopy. This is not a routine test. And looking for things when there's a suspicion that the transthoracic echo may not be showing the entire story. For a variety of reasons, some that Daphne just mentioned with regard to serologies. Sometimes we hear murmurs we can't explain with the transthoracic echo. Sometimes the patient has symptoms we can't explain with the transthoracic echo. So probably in about, I would say in my practice, maybe 10% of the time when something doesn't quite make sense, we'll refer them for a transesophageal echo, which is done at the hospital. It's done as an outpatient. It takes about 5 to 10 minutes to do. It's done with an anesthetic like an upper GI endoscopy. And it's a very high yield procedure. Anything else on that one?
No, I think that's good. If Plaquenil caused retinal toxicity, can the patient take chloroquine? So no, chloroquine I think has a little more retinal toxicity than Plaquenil or hydroxychloroquine, but you can use quinacrine. So those would be the 3 antimalarials. Do repeated UTIs or pyelonephritis make a patient more likely to have lupus nephritis? And is there any evidence that steroid therapy reduces ANA and therefore reduces organ damage? All right, so for the first question, repeated UTIs and pyelonephritis, though they can, pyelonephritis could scar the kidney potentially, doesn't necessarily predispose to having lupus nephritis or active inflammation in the kidneys. And then regarding the steroid therapy, so ANA testing, if we follow patients over time, we don't always just keep checking the ANA test because it can vary with time. So I may check you today and your test may be 1 to 80. I check you in a year, it's negative. I check you the following year, it's 1 to 160. And that doesn't correlate, ANA hasn't been found to correlate with disease activity. So the ANA itself doesn't necessarily tell us if there's organ damage or not, if that kind of answers the question. So we don't generally follow the ANA, but the double-stranded DNA that I mentioned, that's kind of the antibody test that we have at this time to kind of monitor for disease activity. In terms of, this isn't what's being asked, but Benlysta works better in patients who have positive antibody tests, so who have a positive ANA and who have a positive double-stranded DNA.
We're supposed to stop at 12:30, is that right? I think so. So I have a question for you.
2 more questions.
I have a question.
Yes.
So you mentioned in your talk that there are fewer and fewer rheumatologists currently being trained and going into practice. That's alarming, particularly for this audience and many patients. So why is that, and what can be done about it?
Yeah. So the ACR, the American College of Rheumatology, did a workforce study, kind of looking at the workforce. So basically, a lot of rheumatologists are retiring. So the older generation of rheumatologists are retiring. Arthritis and the prevalence of these conditions is increasing. So we need more rheumatologists. And training programs train a few hundred rheumatologists a year, and there's really not a lot of extra funding or funds being put into rheumatology training programs. So things that have been discussed are using advanced practitioners like nurse practitioners or physician's assistants to kind of help with that. The pediatric population, unfortunately, that's even worse because there's much fewer pediatric rheumatologists, and their training is, I think, even longer, and there's much fewer. So those are some of the things they're looking at to kind of figure out. I think they cited like by 2020, half of the rheumatologists, it was this astronomical number is going to be retiring, and we're not keeping up with the demand based on how many we can train. But then there's foundations like Lupus LA are able to fund, a fellow, and even one fellow can make a difference.
So why do we have a good number here in Los Angeles?
Yeah. So there's a lot of rheumatologists in LA. So I think a lot of people like living here. We have good academic centers, so there's quite a few. But then you go to places like in the Midwest, and some of the programs I even interviewed at for rheumatology fellowship, people are driving like a day to go see the rheumatologist. Another thing to consider would be things like telemedicine. So can we, access rheumatologists or specialists that way? Can we do teleconferencing, or maybe having someone, there doing an exam for us and us kind of using a conference kind of style to be able to get people the care that they need? So those are things that people are looking into.
So it is 12:31. Let's give a round of applause for our amazing speakers who will be back later. Thank you so much also for getting through the questions. That was very impressive. Yep. Yep, we have one that wasn't answered, and I think it was yours, and I'm going to save it for later. But wait, don't go anywhere. Wait. So here's the deal. You have an hour for lunch. You need to be back in your seats at 1:30. Lunch is out in the atrium area. It's going to be a long line to begin with, so take your time. But please be back in your seats actually before then, let's say at 1:20. And then hopefully we'll start on time. Thank you. All right, hi. So now we've all had lunch. We're ready for our afternoon nap and listening to afternoon speakers. So up first, we have a very, very, very full afternoon. So I want to remind you of a couple of things. First, if you have a question, write it down. We'll come up and back and get cards. I promise I will not be moderating questions moving forward. I'm just giving them right to the doctor. And if you need more index cards, you've run out, you can use paper from your little Aurinia book, or you can get more index cards out in the lobby. We are going to have a break, and also after Dr. Shapira talks, both Dr. Shapira and Dr. Skaramangis are going to be fielding more questions. So again, write down your questions. We're going to try to get to as many as possible, and I hope you enjoy your afternoon. You'll see me up here in a little bit. Dr. Shapira, come on up.
Thank you. Hello again. We just met this morning. So, to emphasize the UCLA part, because we're at UCLA today, they're very kind to lend us this auditorium, and I want to thank Lupus LA for providing this educational forum. And it's not just educational for y'all, but it's certainly educational for me as well, because I've been educated about lupus from my patients. When I finished my fellowship at Stanford in 1978, you can do the math. Lupus, heart disease, what was that? Nothing. So I've learned about lupus from my patients, and I see many of my patients in the audience, and this is going to be redundant because you probably know everything I'm about to say, but I hope that you can take a good nap while I'm talking. So typically, you would want to see rheumatologists giving this lecture, but because heart disease is such a prominent complication and end organ involvement in lupus, cardiologists are often involved or should be involved. The cardiology aspects may be a little bit underemphasized with regard to lupus, but cardiovascular disease affects greater than 50% of the patients with lupus, and it is by far the leading cause of death in lupus. So, the heart is a complicated organ. I'm going to try to simplify it from the aspect and the how lupus affects the heart. We won't learn everything or talk about everything about the heart today, but just those things that would be, I think, germane and interesting to this group. There are structures of the heart that we're going to talk about, and we have to understand some basic anatomy to understand how lupus affects the heart. So, as we said earlier today, at the onset of lupus, about 15% of patients will have a heart manifestation. And as over their lifetime, 50%, over half of you with lupus in this room will have a cardiac problem. So the parts of the heart that will be affected are basically every part of the heart. There's pericarditis,
There's myocarditis. So and there's hypertension, and there's coronary disease. So let's talk about what these mean. First of all, the coronary arteries are on the surface of the heart, and we will talk about that in more detail in a few minutes. The pericardium is the lining covering the heart. It's a surface that often becomes inflamed. High blood pressure is common in lupus. That's commonly something that we see and we treat. There's coronary vasculitis, inflammation of the coronary arteries. There's something called Liebman-Sachs endocarditis, which is small little growths, excrescences called verrucae. Verrucae means a wart-like structure. That's the meaning of the word verrucus on the valve. And, of course, there's leakage of the heart valve. And we got a question this morning about a patient who had lupus and who had aortic valve surgery many years ago. And that's certainly a common problem that I see in my practice. Lupus patients, in general, have a 7 to 10 times increased risk of coronary heart disease and stroke. That is an amazing number when you think about it. You think about heart disease and stroke are the #1 killer in the United States, and lupus patients have 7 to 10 times that incidence. This is a slide I'll go over briefly, but this is one that Daphne showed this morning. If you look at this middle group here, the 35 to 44, where the pointer is, you'll see that there's a huge discrepancy between the general population and patients with lupus. So this group of young women, aged 35 to 44, have a 50 times greater risk for a heart attack. So let's talk a little bit about anatomy. Now, why are we talking about coronary artery disease? Well, coronary artery disease is an inflammatory condition just like lupus. And some of the medicines that are used for lupus help the heart in certain ways. So the coronary arteries we talk about are the right coronary artery, which is this artery over here where the pointer is, the left main coronary artery, the left circumflex, and the left anterior descending. Now, I'm an interventional cardiologist, and when patients come in with heart attacks or severe blockages, I take them to the cath lab, and I put in little guide wires, and I put in balloons and stents, and I fix these big vessels. It's nothing but a fancy plumbing job. That's all it is. But we found something very interesting. We found a lot of patients with lupus who didn't have those big blockages. And this has astounded us for years and years. And with the help of Lupus LA, we organized a little study, and I'll tell you some more about that in a little bit. The pericardium is the lining over the heart, and pericarditis is commonly seen in lupus. It is a surface that is has 2 layers. Between the 2 layers becomes inflamed. The inflammation can cause pain when it rubs together. It's typically a pain of a deep breath. It's typically a pain that is better when sitting up, and the pain is worse when lying flat. The next structure, of course, is the valvular disease. Heart valves are these thin, billowy, white structures that I'm pointing to here. This is the mitral valve in the open position, and down and to the right here is the mitral valve in the closed position. Then we have the aortic valve up here, closed position, aortic valve, open position. Most commonly, the mitral valve is affected. The effect on the mitral valve is to have leakage of the mitral valve. Mitral valve prolapse is more common in patients who have lupus. And we get these verrucae that I'll show you pictures of in a minute on the leaflets of the valves. There's also considerable valve thickening. So let's talk a little bit about more particulars and more detail about the heart in lupus. Now remember, this is not abstract. This is going to affect half of our audience today with lupus. So I think it's important to understand these things. We'll talk about coronary artery disease separately, but let's start with just pericardial disease. The pericardium When it's inflamed, it's called pericarditis. Whenever you have a structure and it's inflamed, just take the name of the structure and add itis, and that describes the disease. There's lots of itises in lupus, and we get pericarditis. Now, pericarditis is an inflammation of these two layers of pericardium, but fluid can accumulate between the two layers. Rarely this can accumulate to a huge amount so that you have something called cardiac tamponade, where the fluid around the heart is actually choking the function of the heart. That fortunately is extremely rare. But oftentimes, it's just pericarditis. It's very painful for the patient, and we treat with the medications that Daphne described this morning. Myocarditis is rare. I share some patients with myocarditis, with cardiomyopathy due to myocarditis, an inflammation called lupus myocarditis, and it's fortunately very rare, but it's quite difficult to treat. Now, myocarditis can be due to a myocardiopathy, rather, a weak heart can be due to ischemic. Patients may have had a heart attack, and now they have a weak muscle, and now they have heart failure. It can be due to untreated hypertension. If you don't get the hypertension treated, it puts a stress on the heart. We call that hypertensive heart disease, and it's one of the most common causes of heart failure. You're going to see that my talk is very repetitive because there's a few points that are so important they need to be emphasized, because if you don't treat these little things, they become huge, and this is what ends up at the end of the day being the biggest problem. Now, there are certain medications that can be toxic to the heart. The antimalarials, hydroxychloroquine is less so, chloroquine more so, and Cytoxan, to name a couple. The valvular heart disease we talked about briefly with regard to the verrucous endocarditis, the growths on the heart valve, the thickening of the heart valve, the mitral valve prolapse, and the leakage of the heart valve. We had a question this morning about AV block and complete heart block, and lupus can affect the conduction system and cause heart block. Conduction abnormalities also occur fairly frequently, and you can even have it in neonatal lupus, where a patient can be born with heart block. So, if we look at risk factors, now remember that they're both inflammatory diseases, coronary artery disease, which we were going to talk about separately, and lupus is an inflammatory disease. So in some aspects, when we say a patient is having a problem with their heart and they're in a lupus flare, if you treat the lupus, you're treating the heart. But over the long haul, many of the medicines that we use for lupus are adverse to the heart condition. The traditional risk factors are age, which we can't modify, body mass, which we can modify. So yes, traditional risk factors are important. The older you are, the more likely you are to get heart disease if you have lupus. If you're obese, you're going to have more problems. Diabetes, you're going to have more problems. Dyslipidemia, more problems. Homocysteine, which is an endothelial factor, more problems in lupus. Hypertension, more problems in lupus. Menopausal status, which I think Daphne will talk about. And tobacco use, all of these are adverse. Now, the important part about this slide is realize that there are very few absolute facts in lupus. There are studies on both sides of almost every question. And so that's why we learn from our patients every day, because there is no clear-cut answers. We didn't learn about lupus from, at least I didn't learn about lupus from books. I learned about it from my patients in the audience who I see, who teach me every time they come to my office, and they tell me how they feel, and I assess how they did to certain medications, and that's the way we all learn. The non-traditional risk factors in lupus are, there is, of course, with corticosteroids, an improvement in the inflammatory aspects of coronary disease below a certain level, but above 7.5 milligrams, which is a number that Daphne mentioned this morning, there is an increase, acceleration of atherogenesis, of formation of plaque. So 7.5 milligrams is a good level from the aspect of the heart to try to stay at or below. with regard to therapy with steroids. Of course, renal disease accelerates atherosclerosis. The disease activity accelerates atherosclerosis. The duration does, and the amount of other organ damage does. Now, but just to tell you that there is a huge amount of risk just with the lupus itself. So, advice. If you have lupus, minimize the other risk factors. Minimize all of these traditional risk factors, the ones that you can. Take care of diabetes. Take care of your high lipids. Take statins. Diet, exercise, weight loss. Control that blood pressure. Try to not smoke and to minimize tobacco use so that you will reduce your chance of being in that 50% and that high mortality from heart disease and lupus. So a few years ago, we published this paper in 2011, I think, kind of fine print. So we had a problem. So we were seeing patients who would come into the hospital with chest pain. We would draw a blood test called a troponin. A troponin is a blood test that checks for damage to the heart, and they were abnormal. And we would do then some really fancy cardiology tests like a nuclear scan, and then we'd do a coronary angiogram, and they were normal. Yet the patient was having chest pain, there were EKG changes present, and the troponin was abnormal, and we were stuck. We didn't know what to do. So in the true spirit of volunteerism, one of our patients who's on the board now, and she was in the hospital with this problem, volunteered to be a guinea pig for a new type of test we had at Cedars. And it was an MRI of the heart done in a certain way with a certain type of software, with a certain type of machine, with all kinds of crazy medicines given. And she was so tired of being told there was nothing wrong with her when she still had chest pain, she decided she was going to go for it. So she did. So we discovered something very interesting in this patient, that there was a problem, not in the big arteries, because she had a normal coronary angiogram, in the small arteries. So this became known as microvascular disease. Macrovascular is the big vessels that we fix with stents. This is microvascular that you can't see on an angiogram, and you may not see it on standard stress testing. So a lot of patients who've been told forever, look, I know you have chest pain, ma'am, but you don't have coronary disease, you don't have pericarditis, and your valves are fine, and your nuclear test is fine, and your coronary angiogram is normal, there's nothing wrong with you, isn't true. So we called a bunch of patients back in, retested them, and we found a very high positivity rate in these patients. So we published this paper in the Journal of the American College of Cardiology, a cardiology journal, Myocardial Ischemia in the Absence of Obstructive Coronary Artery Disease in Systemic Lupus Erythematosus. So we were able to actually bring a whole bunch of patients back who had symptoms, who were told there's nothing wrong with them, and now we had a diagnosis, and we have an approach with certain medications, that some very conventional, some kind of esoteric heart medications, but things like ACE inhibitors, things like beta blockers, especially carvedilol, statin drugs to lower cholesterol, which lowers inflammation in the coronary arteries. It's not just to make the numbers pretty, your cholesterol numbers pretty. It actually lowers the inflammation within the arteries. Nitrates sometimes, a number of other techniques like ECP, which is this way to improve coronary circulation. And another one called ranolazine, which is one of our funny little drugs. So we were able actually to considerably help this group of patients. So if you have been told that your heart is fine, yet you have chest pain, you should look into this. This is just a picture from one of our studies where we were actually able to show in this patient who is very actively involved in Lupus LA that we found the problem, and it's this little black stripe right here between these two white stripes that demonstrates a problem that was missed on every other test that she had ever had, and she had been tested extensively. Yes.
Can you change the percentage to 100? I have a request in the back of the room to make it larger.
Can we make it larger?
Yeah.
Yeah.
Just use this.
You mean I could actually see it too? Yeah. Okay, sure. Does anybody really want to see this? Yes, I can. I can. Although, yeah, it's actually what I want to show is at the bottom. Yeah.
Is that all right with you to do that? Is that okay?
Yeah. No, I've got it handled here. Yeah. I just wanted to show you guys that I had some slides. You don't really have to read this. Anyway, so echocardiographic studies. Let's talk about echo. There was a question about it this morning. It was a really good question about doing echoes and how often should we do them and should you have one. I think every patient who has lupus as a first diagnosis should have a transthoracic echo and an EKG, no exception. No question. If it's normal, then it would be up to your course. It'd be up to how you're doing in your own doctor's judgment to decide when the next one should be. Of course, if you have active disease, I would say every year. If your disease is quiescent, then less frequently, perhaps. This is just a slide, and you don't have to see these numbers, and I apologize that they're so small, but really there's nothing that good to see here. But I will enlarge it anyway. There we go. Okay, just to show that when we do echoes on patients, just plain old transthoracic echoes, that many studies have been done to see how often there's abnormalities, and we find that the average is around 29% abnormal, that number right there. But if you look at the one study here that was transesophageal echo, the study by Crozier, 54% by transesophageal echo turned out to have abnormalities. So if we took the people with lupus in this room and we did transesophageal echoes, we would find heart involvement in more than half. The incidence of valvular abnormalities is very large, and I'm just going to point out one study here in this big list. It's this one right here by Roldan. And the reason this one is so interesting is this is a transesophageal echo study where they found the number of patients with this growths on their heart valve, 43%, and thickening at 51%. So over half the patients had involvement by transesophageal echo, another confirmatory study. Of course, and I think as we talked about this morning, if you have an antiphospholipid antibody, most studies have shown that you're more likely to have a heart problem. So that's an important factor to know with regard to your heart. So it's important for me to show you what I look at all day long in terms of heart studies and try to figure out and what we do. And so when we look at these little verrucous endocarditis, where these arrows are pointing, are these little wart-like things that are sitting on the valves. And we can see these on the echo for a transesophageal echo. If they're greater than 1 millimeter, it's more sensitive. For a transthoracic if they're greater than 3 millimeters. So it shows you the difference in the sensitivity of the two techniques. So first of all, I would like to show you just a movie of what these echoes look like. And I'd like to show you how we try to make this diagnosis. And I think I can make this movie start. It worked before during rehearsal. Yeah, you think that one right there?
Yeah, go back up top.
You can do it for me.
I can try.
Sure.
Here.
Which one do you think? No, that's embedded within the slide. It came up before down below the lower picture. Now that's the next slide. That's forward. So come on.
Yeah, I
back.
got nothing. I'm gonna let him help.
All right, great.
Sorry.
Hi, how are you? So there's two movies. Yeah, this one, please. No, actually, this is the wrong movie. There's the slide before. It's embedded. Oh, yeah. See there?
Where's it? Right here.
There it is. Cool.
That's it, right?
Thank you. That's perfect.
So it's
Thank
down-
you.
It's down the bottom of that window.
Thank you. When you tried it, it was, of course. Not for me. Okay, so this is an echocardiogram, and this is what we see with the transthoracic echo. So I want to point out a little piece of extra tissue that hangs off right in this area. And you see that little finger hanging off there when it closes, open, close, close, close. That represents verrucous endocarditis, also known as Liebman-Sachs endocarditis. And this can create a stroke. How could that create a stroke? Piece breaks off, circulates into the left ventricle. It's then pumped out to the heart, out of the heart, into the aorta, and where does it go? If we're lucky, it goes someplace innocuous like our left kneecap or our liver. But if we're unlucky, it goes to our brain and causes a stroke. And these little things break off. This is something very important to diagnose because treatments with certain lupus drugs, that Daphne will tell you about, and anticoagulants, like antithrombin agents, can help to prevent strokes in these patients. I want to show you another picture of, and this is the next one, I think, yes. There it is. I did these myself. Can you tell?
It's above it, right?
It's down there. It's at the bottom.
It's this one, right?
Yes. Is it going to play though? It's playing. Oh, great. Okay. Thank you again. So this is the aortic valve that's swinging back and forth. And you can see that there's a huge vegetation on there. Now, vegetation is not just an abnormal valve, but it's where there's been a growth of more material, more than just the verrucous endocarditis. Now what we have is a bacterial colony that's now created a lot of fibrin and clot and white blood cells and pus cells and bacteria on the valve. And the valve is destroyed, and that valve is leaking severely, and this valve will need to be replaced after the patient is treated for endocarditis with at least 6 weeks of IV antibiotics. Now the real question comes up of should patients with lupus who have active lupus be treated with prophylactic antibiotics when they go to the dentist or another procedure? So by show of hands, those with lupus, have you ever asked your doctor that question? Has anybody ever asked? Okay. Now, so of those who raised their hands, who has been told to take it? All right. And the rest have been told not to take it. Okay. So there is no studies to answer that question. So I have no definitive answer for you. And my thinking on this has evolved. And even as, I think it was last Sunday, I emailed Dan Wallace and said, Dan, what do you think about this question? And he says, as you know, there's no studies. That the American Heart Association and the American College of Cardiology, which are my societies, have totally ignored this group of patients, totally ignored, silent on this question. It's a huge question. That we're giving immunosuppressants to patients who now have a harder time fighting off infections, and we're doing dental work. So how do we, it makes sense to give them this. And so many of them have these lesions already on their valves. So should you take it? Well, it's a very good question. We tend to be, to try to be conservative, and so oftentimes we do say yes. So I think it's a good question to re-examine with your doctors next time you go to the doctor. I think the pendulum is swinging toward more treatment. After 2007, cardiology guidelines came out from the American Heart Association that stopped almost all prophylactic antibiotics when you go for dental work or other procedures, except if you've had endocarditis before, or you have cyanotic congenital heart disease, or you have had a prosthetic valve, or you have prosthetic material or sutures in your heart. So it's a good question. I encourage you guys to ask your doctors again on what they recommend. And it may stimulate a thorough workup to see if you have any underlying risk factors in your heart, like a verrucous endocarditis or thickening of your valve or other things that would predispose toward an infection. Okay, so we talked briefly this morning about things that can affect the heart regarding treatment. So let's talk about non-steroidals. Non-steroidals are the backbone of therapy, of course. And anti-inflammatories are so important to treat lupus. As cardiologists, we have a hierarchy of anti-inflammatories that we prefer as opposed to others. And I think Daphne may have some different opinions on this. She's already shaking her head. But from the point of view of a cardiologist, assuming that you have coronary disease, which is quite likely, we like to give aspirin. Aspirin is an antiplatelet drug, and platelets are very involved in causing blockages to increase within the coronary arteries. The anti-inflammatories can be counterproductive because they cancel the benefits we like of aspirin, not the anti-inflammatory effects that may help pain or other things like that, but it cancels the benefit that we as cardiologists want. So the worst offender from our point of view is ibuprofen. It cancels, and so ibuprofen for a heart patient, we just get really upset when we see on ibuprofen and look for ways to change that drug. Probably the one that is the most neutral, it's sort of aspirin neutral and doesn't do anything either positive or negative, is naproxen. And Celebrex is, I think the jury is still out on Celebrex. As you know, some anti-inflammatories, a cousin of it called rifaximin or Vioxx, was taken off the market voluntarily by Merck in 2004 when it was found that this wonderful anti-inflammatory that some of y'all took maybe, one, that caused heart attacks wholesale. And that was voluntarily withdrawn by Merck, so you can imagine what the true story was. Celebrex, though, passed muster. Somehow Pfizer got it through, and it seems to be okay. So if we have to have something, Celebrex seems to be okay for the time being. So corticosteroids cut both ways. Above 7.5 milligrams a day of steroids chronically, we feel as though it increases atherogenesis. 7.5 and below, not so much, and may be beneficial from the standpoint of an anti-inflammatory. We know that NSAIDs aggravate heart failure. We know that arrhythmias are caused by NSAIDs, particularly atrial fibrillation. There is a correlation. Atrial fibrillation, as you know, is advertisements on TV all the time about that, with regard to drugs like Eliquis and Pradaxa. And it's very common. Millions and millions of Americans have it, and of course you have an increased risk with lupus. And NSAIDs cause hypertension. They also aggravate heart failure. We feel as though it's always a balance. It's a plus minus between how much anti-inflammatory you want to give to relieve your patients of some symptoms versus other risks for the heart. And we frequently negotiate back and forth. I call the rheumatologists all the time and say, what can we do about this? What can we do about that? And so we try to come to a happy negotiation that's best for the patient. There are some drugs that are used by rheumatologists that worry us more than others. Cyclosporin, we feel as though leads to hypertension. Hydroxychloroquine, which is commonly used, an antimalarial, does have some myocardial toxicity. It's rare. It does relate to congestive heart failure. It can prolong the QT interval, which is an interval on the EKG that, if it is prolonged, can predispose toward sudden cardiac death, and is a particular type of arrhythmia called torsade de pointe. It can also lead to AV block. Benlysta has got a very low profile of side effects for the heart. We like that drug, and I have at least one patient here who takes it and is happy about that. And Rituxan can cause arrhythmias, and it can aggravate hypertension as well as be hypotensive. Now, in patients with heart disease and who have these problems already, they have heart failure, you have coronary disease, you have arrhythmias, and you're getting infusions or taking these drugs, you need to be monitored more closely, more carefully, more frequently. And during the IV infusions, I'm sure y'all do heart monitoring. Oh, that's Daphne sitting back there. That's why I keep looking there. Y'all can't see her. That's why they monitor patients in those circumstances. So let's talk about the last slide, which Daphne and I stole from the same source. Talk about the things that you can do for yourself to prevent the number one killer in lupus patients. Exercise. Now, we talked about brain fog this morning in one of the questions, and I think that cognitive therapy is great and psychiatric therapy is great. I think exercise helps brain fog. You know, I'm a cardiologist. Personal opinion, I think it's one of the best things that you can do for brain fog. PT, OT, workstations, which Daphne talked about. I think that you have to be very aggressively vigilant for hypertension, hyperglycemia, diabetes, dyslipidemia, high cholesterol, obesity, and smoking must be stopped. Modify the risk factors that you can modify. You can't change your age and your gender and your disease, but you certainly can modify many of your risk factors. I think for high-risk patients that the annual EKG, the annual chest x-ray, the duplex scanning, stress test, when appropriate, 2D echo, are very important. Now, we haven't touched on pulmonary hypertension. That's a huge subject, and it's very important. We just don't have the time today. And the APL, antiphospholipid antibody for screening, is very important because if you're positive for one of those, it increases your risk for verrucous endocarditis, for vegetative or bacterial endocarditis, and increases your risk for coronary disease and sudden cardiac death as well. So with that, what a fantastically depressing talk. I will tell you that it's just astounding how well the patients do that I've been taking care of for so long when they pay attention to the details, when they take care of themselves, when they go for their checkups. And to really put these statistics in perspective, because you're going to go home and think, my God, 50%, I'm dying next week. But you have to put this in perspective. These are from large population studies. These are from folks that do not have the medical care that you guys have access to. And I mean, the scariest thing I heard today was there's not enough rheumatologists. But with good rheumatologists, with the good care that you can get, these statistics should not apply to you. These statistics apply if you don't get the far above superior average care, superior care that you'll have access to if you avail yourself of it. This is just average across the board general population study. So that is sort of a darker picture than y'all should have to bear. I think that's it.
We're gonna, I think we're gonna do like financial questions. You want to sit down and all right, we have about 10 minutes for this section for questions, but I have heard that that they will answer questions if we collect them through email. So send them on there. We're going to do our best. We only have 10 minutes.
Okay.
And then we have a first question.
All right, so we're not going to be able probably to get through all these in 10 minutes, but I'll take them and I can answer them through email, and then maybe we can just send out the answers for the questions that don't get answered, if that's okay. So first question, if I'm on immunosuppressants and BRCA2 positive, are my chances of breast and ovarian cancer higher? So BRCA2 is a gene for that puts people at an increased risk for breast and ovarian cancer. I think the rates of breast cancer in the general population are around 10 to 12%. And if you have these genes positive, you're looking at closer to 50 to 60%, I believe. So you're already at a pretty high risk. Medicines that suppress the immune system in the setting of a known cancer would be a problem. I don't know that it's been answered if you don't already have cancer, if we give you medicines that suppress the immune system, if that would be an issue. But I think it would be a higher risk. So I can't quantify that, but that would be a consideration to have prophylactic surgery. I don't know if you have anything.
So I've got another question here. What is the name of the test done which showed What is the name of the test done which showed myocardial ischemia, discovered problems in small arteries? It's a cardiac MRI with regadenoson stress, abbreviated. CMRI stress. And it is a test that is, there's an MRI scanner on every corner in Los Angeles, but that doesn't do it. You've got to go to a specialized center that really understands how to do this, has the proper scanner, has the proper software, and the proper cardiologist to interpret these scans. This is not an easy scan to do, and it takes several hours to do it. It's easy for the patient. It's just a lot of, laying still, having your picture taken. There's no radiation involved, which is nice. It's a repeatable scan. And we have shown, and it's been confirmed, our studies have been confirmed by the Johns Hopkins group studying the same thing, that this is a phenomenon that when we can identify it, we are able to treat patients and really improve. Now, if they're negative for this scan and they still have chest pain, we have nothing yet, but we're still looking for other factors to identify that might qualify these patients. And I will just tell you, there is this anonymous medical center about 3 miles east called Cedars that does a scan very well. I don't know if it's done at UCLA, and I'm unbiased. I'm on the staff and faculty of both places, but I don't think they do it at UCLA yet. They will. Should lupus patients see cardiologists yearly? I think that's, initially, yes. And I think that, especially if you have active lupus, and for sure more often than a year if you have active cardiac disease of one of the types we discussed today. A specialized cardiologist, I think so, because many cardiologists just don't appreciate this, and they don't understand this. Have you found that? Yeah, it's just not.
It's not really taught in medical school, I guess, and maybe depending on where you train, it's just not as prevalent. Just kind of depends on what population you're working with. So I don't think always general cardiologists are as in tune kind of with how prevalent this can be.
Where do you want to go next?
So I can do a few here.
Okay.
All right. So what is DHEA? So DHEA is a male hormone. So generally we don't use it in males. It's kind of, I guess, considered a supplement. It's There are some studies looking at it in lupus. Again, it's a non-FDA approved treatment. It can help with things like fatigue, hair loss a little bit. Not everyone is using it very commonly. There are some side effects because it's a hormone and a male kind of hormone with like excess hair and other things. So I'll kind of leave it at that, but that's something you can discuss as a potential. What are some long-term effects of Cellcept or mycophenolate? Some of the concern over many years, so one would be infection, so increased risk of infection, especially if your white blood cell count can be low, so we do monitor that. Another would be some people are concerned about the potential for cancer if you're on the drug for many, many, many years. This medicine has been used longer in the transplant, so patients who have a transplant, either heart or kidneys, end up on this medication, so some of the data comes from that. But I would say otherwise, we do monitor very closely, and a lot of people aren't on the medicines for more than 10 years necessarily, the same drug.
Can I butt
So
in?
maybe like 2 more questions, and we're working through our break, so there's no break.
All right,
'cause you have so many questions.
My esophageal spasms can trigger severe heart attack, like pain. How can I tell the difference if I suffer a cardiac event? It's hard to tell. It's substernal pain. It feels tight. It's squeezing. Both may radiate to your jaw, your shoulder. It's hard to tell, and cardiologists have a hard time telling, and you should go to the doctor and let them examine you and test you to figure it out. It's a very commonly mistaken symptomatology. You certainly don't want to miss a heart attack, and it's okay if it's only esophageal spasm. It's fine. So you had your heart checked. That's great. Is there anything that can be done to treat existing plaque buildup? Yes. In other words, can you remove damage that has been done already? Yes, you can. First of all, if you can just stop it right there or slow it down. Is regression possible? It is, but it happens, but we can't really reliably create regression. Regression means make it better. But if we can stop it from progressing, and we can treat with medication and stop complications, then we're a long way. So yes, there is plenty that can be done with existing plaque buildup. Your turn.
All right. I have the SSA antibody, and my daughter was born with a heart block. Could the heart block be cured if known ahead of time? So people who have SSA antibody positivity and who become pregnant need to have fetal echo. So there needs to be an ultrasound happening of the fetus during certain weeks. So I think it's week 18 to week 24, because there is a risk, though very small, of having a heart block. The antibodies can cross the placenta and cause heart block in the fetus. When the heart block is already complete, there's nothing to be done. But if it's picked up on the echo prior and we see, a first-degree AV block or another block, we can treat that. And the thought is by using Plaquenil in pregnancy in patients who are SSA positive, we can decrease that risk also.
Okay, last question.
I am not clear from discussion. Should we take aspirin or ibuprofen for small symptoms? You go first, and then I'll...
Gonna find another seat. I don't know. All right. So I generally try to not have people, if it's, once a month you're taking an ibuprofen, that's okay. I try to have people not take ibuprofen, even Aleve, every day. To me, if you're taking it multiple times per week or every day, that it's not appropriate. But if you have a headache or you have, a knee ache, I think an ibuprofen is okay. In terms of aspirin, I usually use aspirin. So if someone has these antibodies, antiphospholipid antibodies, and have never have a blood clot, I put all those patients on a baby aspirin as kind of a preventative measure. Your turn.
I agree. And, of course, I'm making a face here about the ibuprofen because read the cardiology literature, and ibuprofen is just, cancels the benefit of the aspirin as far as your heart is concerned. So we prefer naproxen. Now, are we doing our patients a disservice if they've just been to the rheumatologist, and the rheumatologist, they always say ibuprofen, I know. And so we say, no, take naproxen. Is it as good? Does it work as well? And are we doing the patients a disservice by telling them to take the naproxen instead of the ibuprofen?
So I generally don't use much ibuprofen because I don't think it lasts as long, so I don't think it's as beneficial. So ibuprofen needs to be taken multiple times per day, usually every 6 hours, every 8 hours. It just doesn't last as long, whereas Aleve or naproxen is, can last up to 12 hours, and I find it's a little bit more tolerated. So I generally use that, but I will say is that what one anti-inflammatory works in one person doesn't necessarily work in the other. So I do have people that really don't think Aleve works whatsoever, but if they take, a meloxicam or ibuprofen, that helps. So we'll sometimes switch it around. But again, I think it's advised to not be taking these things on a daily basis.
All right, thank you so much. And we will try to get answers out to the rest of the questions, because I know that there are many. Okay, friends, we really do need to move on. So have a seat. We have so much more to go through today. I see some more people out in the hall. Come back. Please. I know a lot of you are on Plaquenil. You'll want to hear this. I'm sorry, what? Well, we're about to find out. We're going to find out right now. Come on in. Come down. Come sit. All right. Our next presenter is going to talk about retinal toxicity associated with Plaquenil use. Dr. David Lazar is a vitreoretinal surgeon. I had to learn that word. It's a tough one. Thank you. And researcher who's active in his field and is currently a co-investigator. Okay, we're about to start. Thanks. A co-investigator in several national clinical trials for the treatments of dry and wet macular degeneration. As a reminder, questions at the end, write them on your index cards. We're going to do a better job about getting them more quickly. So please welcome, I got to put this on for you. Fabulous. Dr. Lazar.
Thank you so much. Thank you.
And you can use this to move it, or you can use we'll just use these two.
Okay.
Thanks.
All right. My name is David Lazar. I'm an ophthalmologist, and I also did 2 extra years of subspecialty training in medical and surgical diseases of the retina. And I'm going to be talking today about retinal toxicity associated with Plaquenil use. So before I get started and scare everyone here, I just want to say that Plaquenil is an extremely safe medication, an extremely common medication. But just like aspirin or any other medication, there's side effects. There's potential side effects. And the problem with Plaquenil in the retina is that the side effects can be catastrophic. So it's very important to understand what the side effects are, what the risk factors are, who's at risk, and how we can prevent it. So first things first is, what is the retina? I tell patients that the eye is really analogous to a camera. The cornea and the lens of the eye, and if you wear glasses, glasses, those are all the lens of a camera, and the retina is the film of the camera, right? So the retina is the back part of the eye, just like a camera, where the film used to be, and and so the retina sits on the back part of the eye, and the cornea and the lens focus light onto the retina. The retina sends the signal to the brain, and the brain says that's a microphone, something like that. So these top two pictures, here is what it looks like when I look into a patient. If you were to dilate my eyes and look directly into the back part of my eye, that's what you would see. And this is the retina. This is the film of the camera, okay? And of course, it's the most important part, right? So you see how it's nice and red in this picture? This is what it looks like in real life. It's nice and red because the innermost layer of the retina is pigmented. And actually, that is the layer that's affected by Plaquenil toxicity. So you'll see some pictures later on what Plaquenil toxicity looks like. So this is a healthy retina with a nice pinkish glow. This is just a red-free filter. And then if you took a cross-section through the center part of the retina, this is what it would look like. These are the cells of the retina right here. And it's nice and layered. It's a layered structure. There are 6 cells that sit on top of each other with the pigmented layer right here at the bottom, okay? And So this is what it looks like under a microscope. This is what it looks like in our office. We have really sophisticated and expensive imaging techniques. This is called a tomogram. I don't know if you've ever been to an ophthalmologist, or even some optometrists have this. It's called optical coherence tomography. It's a very, very safe imaging technique that basically lets us look at the retina as if it was almost as good as looking at under a microscope, which is very unique to medicine. There's not many imaging modalities like that. So this is all normal. And by the way, the rest of the presentation is pictures. So you're going to want to be familiar with what normal looks like, okay? So this is normal. Now let's move on to plaquenil and how it affects the retina. So what are kind of the symptoms of plaquenil toxicity? These are quotes taken from a patient who has severe plaquenil toxicity. And the first quote is, "The first thing that happened was I couldn't read my digital clock because the bars, the light were broken. Then I noticed I couldn't see well out of a donut-shaped area of my right eye." This patient later went on and had cataract surgery, which is the removal of the lens, the front part of the eye. And after the surgery, the blind area was more noticeable because my sight had gotten so much better. So basically, go back to the camera analogy. This person had damaged film, right, from the plaquenil, and had a new lens put in to think that that would solve the problem. But if you have damaged film, it doesn't matter what kind of lens you put into that camera, you're going to get a bad picture, right? So what is the prevalence of plaquenil toxicity? It's about 7.5% if you've been on plaquenil for over 5 years. So what you'll see, one of the take-home messages is the longer you're on plaquenil, the higher your risk, okay? So it's estimated that 7.5% of patients who have been on plaquenil greater than 5 years have some degree of toxicity in the retina. And if you've been on it for over 20 years, you have between a 20 and 50% risk of some toxicity. So the longer you're on it, the higher the risk. What does it look like under the microscope? So this is a zoomed-in picture of plaquenil toxicity, of a retina with plaquenil toxicity. And like I said, here's normal, here's the inner retina, and here's the pigmented layer that's so important. See these pigment cells? And look, what happens here? They stop. They kind of die off, and there's no pigmented cells over here. The role that these pigmented cells, their function is to keep the whole retina, the whole rest of the retina healthy. So without these pigmented cells, everything above this is non-functional. This is all non-functional retina. And then it starts where the pigmented cells are, then this is functional retina, okay? So it's really a critical layer. Now, it's not all or nothing, right? There are varying degrees of toxicity. So I just want you to focus here on this column here, and this is just the degrees of toxicity from plaquenil. And it might be tough to read but I look at these all day, so it's not. But if you look at this is normal here. This is a normal pigmented line, okay? And just follow as we move down, that pigmented line is going to get more and more disrupted and even missing. So here's normal, and here where this arrow is, you see there's a break in the pigmented area, and then even more toxicity. It's almost all gone where this is, and then in this bottom one, that pigmented line is all gone, okay? So the whole point of this slide is just to show that there's varying degrees of toxicity. You don't just wake up one day and you have end-stage toxicity from plaquenil. It's a varying scale, okay? This is end-stage plaquenil toxicity as if you were looking right into the patient's eye. And contrast that to what I showed you in the first slide. Remember that donut-shaped area the quotes that lady was talking about? What does that look like to you? Looks like a donut to me. So this is the normal image of the retina, and this is just a red-free, just something that ophthalmologists use. Focus right here. There's a ring of depigmentation. Remember, it attacks the pigmented layer. So plaquenil toxicity has taken away the pigment in the central vision and left this poor patient with a ring that is in their central vision. Luckily, no one understands why, but luckily the central vision, what you use to read, your best vision, is right in the center of that donut. So that's preserved. However, there's a donut around your central vision that you can't see out of, or this patient can't see out of. So this is end-stage disease. If this was you, this is the ball was dropped here. Most patients, when they come into my office, have this level of disease, so this again is a normal tomogram here, and look at the pigmented layer, and then follow it down here. There's breaks in the pigmented layer here, and breaks in the pigmented layer here, and it's actually called the flying saucer sign. because if you kind of take this flying saucer and move it down, it kind of looks like a flying saucer, right? So this is like the intermediate level of damage. It's not as bad as the previous picture I showed you, but you know, the whole goal, as far as I'm concerned, is not to even let it get this far. Okay, so that's the level that I see most, is the flying saucer sign. Now the point of this slide is it's going to prove that diagnosing early plaquenil toxicity is extremely difficult. Okay, so these are 5 different imaging modalities taken from one patient with very mild plaquenil toxicity. Okay, so these are all from the same patient, different techniques of imaging the retina, but only one showed toxicity. Okay, so only this, and it doesn't matter. I won't point out where it shows it, but the point is, you have to be very diligent and very aggressive and have a high degree of suspicion if you suspect if you're an ophthalmologist and you suspect plaquenil toxicity. Because look, if the ophthalmologist only did this imaging test, it would have been missed. If they only did this imaging test, it would have been missed. Okay? So it's very challenging to diagnose early disease. You know, it's not hard to diagnose this, okay? But I don't want to diagnose this. I want to diagnose this. I want to diagnose the earliest possible sign of toxicity. Now, why is that so important? It's so important because even after you stop Plaquenil, the retinal toxicity can progress, okay? So it's really critical. So this is a patient, this is the right eye, okay? And this is their tomogram from 2011, and it shows Plaquenil toxicity. What's that sign? Flying saucer sign, right? And now flash forward to 2017. They were stopped in 2011. Go forward to 2017, and the toxicity has progressed dramatically. And I don't know if it's convincing, but if you look at the pigmented layer, it's basically all gone here, and it's all gone here. So this is after stopping the medication, it can still progress. Okay? And here's her other eye. 2011, when it was first diagnosed, flying saucer sign, right? Does everyone see the flying saucer? Okay. And then flash forward, worsening of the toxicity here and worsening here. Having stopped the Plaquenil, okay? So it's key to stop this medicine at the earliest sign of toxicity, just because it's good medicine, number one, but also because it can progress. This is well documented. These images were taken from my practice, but this is well documented in the literature. This is just a very famous picture taken from ophthalmic literature that shows the same thing. This goes this way. These are 3 different patients, and this patient had plaquenil toxicity with breaks here and here. They stopped it. 3 years later, it got worse. Same thing. 3 years later, got worse. Same thing. 3 years later, got worse. And these are 3 different patients. So this isn't. I'm not discussing something new or novel in my practice. This is something that's well known in the retina community. Now, this is a technical slide. The whole point of this slide is that this is an area of active research with retina doctors. It's not like we've closed the book on plaquenil toxicity in the retina and we're no longer interested in it anymore. This was just published last month in one of the big retina journals. And it's basically what the publishers were looking at was looking at the reflective layer of this inner retinal layer and thinking that maybe looking at the reflection might be the earliest sign of plaquenil toxicity. Highly technical slide, but the only reason I put it in here was to make sure everyone understands this is an active area of research, that we're still interested in getting, how can we best predict early toxicity? So what are the risk factors? If you are on a high dose Plaquenil, if you have kidney disease, if you have any other diseases of the retina, like if you have macular degeneration as well, and if you're on drugs that are not good for the retina, like tamoxifen. These are all risk factors to getting plaquenil toxicity. And this is also a very famous slide here, and this goes back to what I spoke about earlier, which is here in the x-axis we have years, here in the y-axis we have risk. So the higher up, the higher the risk, and the further this way, the more the years. And this is 3 different graphs. This is patients on low dose Plaquenil, medium dose Plaquenil, and high dose Plaquenil. And all it shows is what I talked about earlier, which is the longer you're on the medicine, the higher the risk, and the higher the dose, the higher the risk. And those are the 2 most important risk factors is the dose and how long you're on it. So you want to see your rheumatologist to make sure you're on the right dose. Number one, you don't want to be over-medicated. And if you're on it for a long period of time, you want to make sure that you're getting screened appropriately. So this is the last slide. What are the take-home messages, I think, from this short presentation? Number one is that the risk of toxicity, retinal toxicity, is directly proportional to the dose of the medicine and the length of time. The damage from Plaquenil is not reversible. I think that's really important to stress, that once the damage occurs, it is not reversible. That's why it's so important. If caught early, minimal damage may occur, although in rare cases it can progress, like we talked about. And all patients on Plaquenil should have a baseline retina exam and repeat exams as determined by the length of time and their ophthalmologist. So it was really nice being here. Thank you very much for having me. I appreciate it. Okay. Good, very good. Ooh, long questions. So this is a good question. What is considered low, medium, high dose of Plaquenil? That's a very good question. It's really determined by weight, or traditionally it's determined by weight and height. Oh my God. Some people, these novels I'm going to have to email back to you. I can't. So how do you determine the right dose of Plaquenil? Great question. Really, I don't want to touch on that too much because that's really the rheumatologist department. You need to work with them, and they're up to date on what the most current way of measuring the appropriate dose. However, traditionally, it's based on height and weight. Amazing.
You're super popular.
This is great. Just cut me off when if I run out of time. Okay. Should we see a specific ophthalmologist for lupus? I think this is. Should we see a specific ophthalmologist for Plaquenil toxicity? It's also a good question. As far as I'm concerned, it doesn't really matter who you see, as long as you're being seen. I do obviously have a bias, but I think that ophthalmologists who are trained in retina, medical and surgical disease of the retina, have dedicated an extra 2 years of training for retinal disease, probably would catch Plaquenil toxicity earlier than maybe a comprehensive ophthalmologist. But I think the most important thing is just being seen yearly to catch toxicity. This is interesting. Would you prescribe or recommend Plaquenil to a patient that suffered a CRAO and vitreous hemorrhage? A CRAO is a blockage of the main artery in the eye. As far as I know, Plaquenil is not used for that. And for lupus anticoagulant, that's more up to a rheumatologist for treating those kind of things. It's an interesting question. I've been taking Plaquenil for more than 20 years. How often should I get tested? I think yearly is enough. This is not a disease where you wake up one day and it's that donut. This is a slowly progressive disease that can be very subtle. So yearly exams are sufficient, even if you have toxicity. Even if I have a patient who has toxicity, I don't see them more than yearly because there's not more than I would do other than just stop the medicine. Oh my, this is amazing. All right. Sorry, I'm going to the short ones first. Recent San Diego rheumatology conference held retinal toxicity is the same in general population as Plaquenil population. What, was that you?
It's not me, but I heard that.
So what is that? Because I heard you saying earlier. So what do you mean? That patients who don't take Plaquenil get...
The chances of that...
The chances of that Yeah. So she's saying, I think it might have been maybe misheard or someone kind of misspoke, because this is specifically Plaquenil toxicity. This is patients who take Plaquenil. So people who don't take Plaquenil can get other retinal problems that can be very similar, like macular degeneration can look very, very similar to this. But everything that I've just spoken about are specifically for patients who take Plaquenil and their toxicity, so, and the risk of toxicity. So if you're not taking Plaquenil, you're not at risk for this per se. That's not lattice degeneration. Lattice degeneration is a different thing for people who are nearsighted, and it's thinning of the retina. So the retina is extremely complicated. It sounds like someone either misspoke or a word was dropped, but everything that was just presented was specifically for patients who take Plaquenil and the risk for their toxicity. Once Plaquenil is stopped due to retinal toxicity, is there anything you can do knowing that the toxicity can get worse? The answer is no. The answer is no. That's why this is such an important topic. And again, it is rare. It is rare. Probably in my practice, I have 3 patients, and no one with that donut, thank God. But about 3 patients, it is rare. You just don't want to be that patient, because there's nothing you can do. Can strabismus be caused by lupus? I'm going to say no for that. It's kind of a complicated question, but for the purposes of this talk, I'm going to say no. Oh, can strabismus, which is when your eyes aren't straight, can that be caused by lupus? Really, the answer is no. It depends on what you mean, and it's not really relevant to this talk, but whoever asked that, I'd be happy to, if you come find me after this, I'll go into more detail. Is there anything that can be done once toxicity is identified? We went over that. The answer is no, unfortunately. How often should I be monitored? If you've been on it for 14 years, yearly, I think is reasonable. No more than 6 months. No more than every 6 months. It's such a slowly progressive thing that you don't want to go too often. Oh, this is a good one. Does the baseline retina exam cover the 5 tests that can be determining toxicity? The question is, it depends. Depends who you see. Everyone who comes into my office gets an optical coherence tomography exam. So that's one of the tests. And then if I suspect toxicity, I'll order more. So it depends on who you see. If you go to someone and they just do a dilated exam and they feel that that's sufficient, then no, it wouldn't be covered. Not every ophthalmologist does the same types of tests or number of tests. And if you're not seeing a retina specialist, they might not even have that camera, that imaging system in their office. So it all depends on who you see. It's called an OCT, or an optical coherence tomography. And this is the last question and my favorite question, and the question is, are you single?
Done this has never happened. So, mazel.
Oh, thank you.
You're welcome. You should save that.
Oh yeah, that's good. That's great.
Wow.
So, thank you again for having me. And if you have any other questions, I'll be answering. Thank
you. Wow. Wow. That was impressive, people. Yeah. So here's what we're going to do. We're going to give you a 10-minute break. If you want to talk to Dr. Lazar, he'll be out in the lobby. Now's your chance. So at 3 o'clock on the dot, we are going to do our last session, which is going to be awesome. So please make sure you're in your seats at 3 o'clock, and I'll see you in 10 minutes. Wow. I have to tell you, I'm a little embarrassed on behalf of my lupus people. No. Look, it's a good question. It's a good question.
pictures that I can get to post, like, actually. So I did, like, one, cool shot, because different angles, it's all going to kind of look like the same picture. But I've just been putting everything, like, on our Instagram story and saying who we're talking with.
Just one thank you. Honestly, thank you. Because, yeah, I'm so happy you're here.
That's good?
Up there, and then lower your legs. So lower your legs first. I think the second row only because on that portrait mode, I think, try it. Just do it. If you're sitting in the front row, yeah. Front is better. So then I'll stand over. Do you want to do a...
Better?
You guys are going to talk from there, right? Or you're going to talk from here? What do you wanna do?
I'm
Because
gonna
you
talk
have,
from
like,
here.
Or because you have this will work from there or here. Either. It's up to you. I'm gonna move my stuff on the side.
Is the microphone? Oh, it is long. I might just kind of hover here.
Yeah, do whatever you want.
Cool.
You're gonna do your video first or your...
It's the video is actually in the PowerPoint, so.
Oh, let's get you going. There you go. And you can use the arrows, you can use the mouse, or you can use this thing, which sort of works. And
Skip the slides.
so it's a little.
Test, test. So she can walk around with this mic.
Okay, so do you want to turn this one off?
Sure.
I just don't want feedback.
Right, right. Test, test. I think. I'll turn it off in the back.
So Sheba? Yeah. This is off. Oh, that's not off. Hello? Hello? So you have this one that you can walk around with, but you have to talk very... Hello? Hello? Is this one still... Or that? 1 minute. Thank you for all of you being in your seats. I'm wondering where the other 100 of you are. Nicole. I have nothing to say.
She asked me to get this done. You can either turn it on. You can lift the
Hi, friends out in the hall. If you can hear me, come on back. They can't hear me. Thank you. Thank you for your help. Yeah, I know. It's a horrible microphone. How's this one? This one? Can you hear me with this one? Okay. I'm just going to use this one. You can barely hear me. Can we make this mic a little hotter? It is hot enough? It's good? Okay, never mind. Dr. Lazar has got a lot of people talking to him. Funny enough, he did not answer, did he? Yeah, I know. No, you didn't have to. It's okay. much to make me blush. I'm pretty white and pasty. I blush at pretty much everything. All right, come on back. Kathy Jackson, I see you out there. Come on, you got to get back in here. Come on. When I know your name, I'm going to call you out. Okay, it is 3:01. Sheba and Elle, are you here? Oh, thank goodness. Okay. All right, so we are almost at the end of our time together. I'm going to move this mic away. And our next presenters are here to talk about advocacy. We always do an advocacy piece at every patient conference that we do. It's a very important part of being a lupus patient or a caregiver and being actively part of your care and treatment plan. And we have two very special Lupus LA friends to help us out. The first one is Sheba Family. Sheba's a computer scientist who works in the pharmaceutical field. She also is a lupus survivor and runs a website on lifestyle tips. Sheba's starting a web talk show with her co-presenter, Elle Jones. And I just got interviewed this morning, so I think I'm one of the first episodes, so you all have to watch it. You can send me notes on how I did. And Elle Jones is a powerhouse of positive energy, I think. She's a lupus survivor, award-winning philanthropist, motivational speaker, and lupus advocate. She's often referred to as the stylish, creative storyteller. Please welcome Sheba and Elle.
Thank you so much, Toby. We're so happy to be here, part of Lupus LA, so thank you very much for that. And I have to say that after the talk from the cardiologist and as well the ophthalmologist with retinal toxicity, that we are the fun presentation for the day. So
No shade.
no dangers in this. No dangers in this talk today. Go for it.
Do you each want a mic, or how do you want to do this?
Yeah, because we'll flow up. I mean, we can just use these. That's fine.
So I think Toby gave us a nice introduction. We're both lupus survivors, and I think that at a certain point you want to give back, and that's the itch Elle and I have had, and that's where our advocacy work has come in. And we're now co-hosting a show called A Cup of Tea TV, Tea for Truth, Education, and Awareness about living with lupus. So we'll give you a little preview about that at the end. And just to get us started on the same page, and we're talking about advocacy. So what does advocacy mean? I mean, I think all of you know what advocacy is, but there's so many different areas of advocacy, and generally it's really just to support a cause, and that might be a particular aspect of lupus, access to healthcare. It might be political, it might be economical, so we'll look at the different aspects today. But basically just supporting and backing that. And, you know, some people fear hearing about illness or are afraid to talk about it, or fear of imposing on others. But I just want to point out that we spread awareness in order to heal ourselves and to help heal others. So I believe it's a very positive thing. And why advocacy for this particular talk or subject today, the cause of lupus? And historically there's been a lack of research, and perhaps some of that is the fact that it's primarily affects women, and that we haven't known much about it historically. There's no cure. There's a lack of kind treatments, as we've looked at the side effects of some of the medications today. And there's also a need for patient support. This being a chronic illness, some of the advocacy is just, how do you live with this disease day to day? And that comes in with support from, your social system, but also other people suffering from lupus and healthcare professionals. And there's also a need for awareness. I didn't know what lupus was when I was diagnosed in 2006. And I looked it up on the internet, and it looked quite scary, to be frank. And awareness and looking at the facts is something that's important, I think, with regards to this. And we don't spread awareness, again, to garner pity or to focus on disease, but rather to strengthen ourselves, strengthen our community, to bring people together, to arm them with knowledge, to be able to take control of your health. So types of advocacy, again, fairly straightforward. We have political, whether you're going to your local or federal governments. We have economical, the Lupus LA does a lot of great work for patient programs. We're here today. They have 9 different support groups. Some of it is also institutional, access to medical care, research, and as well social systems. So some of advocacy is really to raise awareness within your community to get the support that you need, to have others just kind of understand it as much as possible. And we do so in a positive and assertive way. Again, it's not a forum to complain or to be talking about lupus, but rather to inspire, to have people come together with a particular cause and to enhance your quality of life living with this disease. So how can you advocate for lupus? So there's a lot of different ways, and I encourage you, again, to get involved with Lupus LA or similar organizations who are doing advocacy work. That can be political, that can be economical, and fundraising in order to help with advocacy. It can be institutional, and as well social systems. So we have a prime example today we are spreading awareness through this new web show that we've created, A Cup of Tea TV. So some of it can be as simple as that, and to get people involved and aware of what's going on with lupus. So one note I wanted to make, this is my last slide before I pass it on to Elle, and that's that lupus is a life force. Okay, it really is a force. Instead of turning, of course, on the outside world, it's turned in on ourselves, but it's a power that we all hold nonetheless. And I think sometimes we mistakenly believe that we need to fight it. And the reason why I say I don't like the term fighting it is because I think that triggers a fight or flight response within your body. And I think the key is to really accepting it and then doing what you can despite it. And so I shy away from saying lupus warrior, you're a lupus survivor, you're somebody, you are who you are, and you just happen to have lupus on top of that, and you're doing what you can with lupus. And so, that is a part of your story. But you're not fighting yourself. Lupus is a disease where your immune system is attacking your body. So I think to think of it as you have to fight something that's within your body is compounding already an existing problem. So I think you have to love and accept your lupus and then work beyond that to change it, to enhance your life, to manage it. So that's one small little point I wanted to put on that. And then I think a lot of us are strong women who have lupus and some strong men as well, and we tend to shy away from help and think that we can do everything ourselves. But I think it's very important to embrace social support. I think that only strengthens us, and as well to be discerning. How many of you are familiar with the spoon theory? Quite a bit of you. So for those of you who are not familiar, you can Google it, the spoon theory, and you'll see it right away. But it's a metaphor for how much energy you have. So you have a certain amount of spoons in a day, and then you kind of will run out of them. You have to be careful where you're going to use your spoons. And I think this comes into social support as well, and your advocacy as well. Sometimes doing something that feels good or that's good for the community can give you back a spoon. And then sometimes, spending time with or giving your energy to something can really drain all of your spoons. So I think advocacy is something that's spoon giving. And I also think that being discerning with how you're spending your time is really important. And in a way, it's a gift that we have with lupus, is that we now have no choice but to really spend time doing the things that we think are important, that are priorities, spending our time with the people that we think are a priority. So with that being said, I will pass it on to Elle.
Thank you, my dear. Thank you, Sheba, for an amazing. I am incredibly honored. I'm very thankful for the Lupus LA family. Have been a partner and a part of the family for at least probably 5 or 6 years now, and have met some amazing people, both women and men, leaders in the community like Sheba, and we have a sisterhood that has just been birthed out of that, and it's such an amazing opportunity. Before I get into, so you'll see my slide and all the things I'm going to be talking about, but before I get into that, I want to go back to something that Sheba said, and that was that it's very important, the social component of dealing with a disease and the social component of advocacy is incredibly important, and it's not something that you can afford to overlook. How many of you, when you first received your diagnosis, went to a family member? Raise your hand. Or went to someone that you're close to share your diagnosis? Okay, a few. Now, how many of you, when you first received your diagnosis, went into denial and didn't say anything to anyone? Okay, about the same. Well, I was definitely that person. Imagine being a 20-something-year-old single mom living in a big city that you have no family in, and dealing with symptoms of something, knowing something was wrong with you for more than 6 years, and then when you finally get an answer to what's going on with you and what has been going on with you, and you get this official diagnosis that you have lupus. Well, I was the one that went into denial. I'm not sick. I'm only in my 20s. I'm young, I'm vibrant, I'm active. This is not, I don't know what this disease is. I don't know anyone who has it. And it was a cross between being in denial and being extremely afraid. So much so that I think the one of the few times that I first spoke the words that I was diagnosed with lupus, every time I would say that to someone, what I was getting back from them was a death sentence. Oh, I know so-and-so has it, or my friend's sister has it, or my neighbor had it, or somebody had it, and they died. So that just pushed me further. Exactly. I was like, yeah, I won't be talking to you anymore. So, but denial was my way of coping with my diagnosis. And I had shared with Sheba recently when we were filming the first part of our new show, I said, I wonder what my life would have been like for those first 5 years after receiving a diagnosis if I had a community, if I had someone to talk to who understood what I was feeling, what I was going through. And I felt isolated. I felt like something was wrong with me, as if I had done something in my life to merit this disease. How many of you can relate to that? How many of you feel like that today? I have a special message for you. There's nothing that you could have done to change the outcome. There's a power that exists within you, and that's your voice. And out of your experiences with lupus, there are multiple stories being birthed. And you have the incredible honor of having a social responsibility to start sharing those stories. And it wasn't until 2011 when I was in ICU on my deathbed. I get incredibly emotional, gosh, when I even think about telling this story, because I know that it's a miracle that I'm here. But it wasn't until, so I was diagnosed officially with lupus in 2000. And I go all the way to 2011 before I decided to use my voice. That's 11 years of walking around, saying nothing. Not just not helping myself, but pouring out from within and sharing with someone else to help give them hope. A lot of times we feel like if we're going through something bad, we don't want to share with other people because we're burdening them. Nothing could be further from the truth. Think about your favorite movie. How many This Is Us fans do we have in here? Okay. This Is Us is a perfect example of storytelling. And there's multiple stories being told in each episode, and we find ourselves in those stories. We cry, we laugh, we become one with the characters. That's what our stories have the ability to do when we so boldly stand up and begin to use our voice and share those stories. So that's what I want to talk to you about really quickly, is taking back your voice in the face of lupus. You don't have to be silent. I don't care what your experience has been up to this point as a lupus patient or an advocate or a leader in the lupus community, whether you've watched a loved one suffer with this disease or whether you have suffered personally. You have a powerful voice, and you should never let anyone else speak for you, because no one knows. I don't know how many, if we had to guess a number, how many people in this room actually have lupus. None of us have the same experience or experiences. So it's important for Sheba to tell her story. It's important for Nicole to share her story. It's important for, I think they're gone, but one of the Mata sisters. There's so many people, Catherine, yes, to share your story. Because what ends up happening is we begin to find that there are some similarities, but more importantly, there's a bond. There's a community that's built around storytelling. And then we can show up and be supportive for one another, and you don't have to go through things alone, right? So what is your story, and what role does it play in advocacy work? A lot of what I'm going to say is probably going to sound very redundant, but it's intentional because I want to drive this message home. Your story and the role that it has in advocacy work is this. I'm here today. Sheba's here today. We have been given the awesome opportunity to share our stories on this platform, but also not to just share the lows of our stories, but to take our experiences and say, this is why I'm passionate about advocacy. This is why I am here doing this work. It's because of my story. Remember, I told you it wasn't until 2011 when I almost died, and then after I came out of that, and I was like, uh-oh, there's more to this, right? I need someone. I need to know that I'm not alone in this. So I started seeking out support groups. And honestly, a lot of what I found online was doom and gloom. And I'm a happy-go-lucky person, even when things aren't that great. So that didn't fit me. So I had to find something else. And then when I couldn't find it, I started creating. And you get out, and you'd be amazed at how much you have in common with other people when you start opening your mouth and just talking, right? That's how I met the Mata sisters. There they are. I thought you guys were in the back. So, yeah, your story plays a very critical role in advocacy. And advocacy is simply just getting out there, using your mouth. Start talking to people. Start telling them how lupus has affected your life, how lupus has affected the life of your loved one. I was just in the emergency room with my son a couple nights ago, and it was a very scary time. And I was talking to the doctors, and I was telling them about my medical history. And we were in a room, two sides, and it was separated by a curtain, and there was a mother and her probably 13-year-old daughter on the other side. Well, after the doctors walked out, she came over to our side, and she said, "I'm sorry to intrude. Can I talk to you for a second?" I said, "Absolutely." She said, "I didn't mean to eavesdrop, but I overheard you talking about lupus and you asking the doctors to run some tests on your son. My daughter was diagnosed with lupus, and they just told us that she's being admitted to the hospital." That woman, prior to that moment, had no one to talk to. As a parent, she was overwhelmed, she was crying, but trying to be strong for her young daughter who was facing hospitalization for we don't know how long. But it was because she overheard someone else talking about their experience with lupus. And I just felt like that was a divine situation for sure. And so again, it just is super important. And so I told her about Lupus LA. I told her about all that I know. We exchanged phone numbers. Advocacy, could be something as simple as that. Doesn't have to be on a stage, doesn't have to be in a big room. It could be, but you have an opportunity every day to share about lupus. That's Sheba's way of telling me to hurry up. Okay.
Or the clicker issues.
Like, get to it, get to the point.
I was warned, though. I was warned that might happen.
Yeah. So we'll get through this really quick. Social storytelling and social media. That is how I have been able to do the things that I've done. I have been able to work with government officials and organizations like Lupus LA and even individuals. Is I started blogging, just writing whatever came to mind. I started creating videos and share any way that I could share parts of my journey and my story of living with lupus and navigating through life with pericarditis. We heard about that today. Hepatic liver disease, we heard about that today. And thrombocytopenia, we also heard about that today. I live with all three in addition to lupus as a result of having lupus. And so I took to social media. You'll see me with my phone all the time, except for now, because I'm very active on social media. Facebook and Instagram and YouTube are amazing platforms, especially with the latest technology developments with live streaming. You can share so much.
So I think we're going to go to the last slide because we want to take time for questions.
Okay, that's fine. So use what you have to share your message is the whole point of that. And so our latest advocacy project is A Cup of Tea TV. We're not going to go all into what is the show about, who's on the show. Obviously, you know by now. So Sheba is going to play just a little trailer for you really quick, and then we'll come back.
Or not.
I'm your co-host, Elle Jones, and
I'm your co-host, Shiva Family.
Hey, Sheba.
And we're talking about living with lupus.
Stories are so powerful, and a lot of times we want to babysit our stories. Like, we want to say, it's okay, we'll protect you. And when you get to a place where you can confidently and boldly share your story, you take its power away, like the negative impact that that story has had on your life, your health, your relationships, your emotions.
Lupus. And we're here to tell our stories, and we're here also to bring a lot of resources, people living with lupus, experts for lupus, for rheumatology. That's it.
So why did we create A Cup of Tea? This idea actually was birthed out of a roundtable discussion that we had with Toby and some other leaders in the lupus community, like Nicole and the Mata sisters. And we were talking about how we can take our work and produce it, or get it out on a larger scale. How can we do more? We all have lupus, or we are supporting someone who has lupus. How can we do even more? And that was just simply to share our story. So A Cup of Tea TV was birthed all over dinner. And we are incredibly excited about this project. We're proud of the work that we've already done in such a short period of time, and we have a lot more to do. And we're excited. We decided to do it on a video platform and share it on YouTube because it will reach the masses. You literally have the opportunity to reach people all over the globe, leveraging the power of video and storytelling.
Yeah, and you all have flyers in your little packets. If you want to look us up, you can subscribe on YouTube, and you'll be notified when we have more videos. And we're also set up.
Yeah. So we are set up in the room just adjacent, right across from here. And so you've heard just a little bit about the power of storytelling. We know everyone in here has a story, so we would like to open up an invitation. If you are comfortable and ready to share a part of your story, we want to offer you an opportunity to be a guest on A Cup of Tea TV, which we are taping in the next room right after we're done. So come see us. You don't need to do anything but show up, and we'll mic you and get you ready. All right?
Thank you. Yeah. So that was amazing.
Oh, thank you.
I'm so excited for a cup of. Oh, you might need this. Okay.
Okay.
I'll take this one. All right. So I want to make sure that there's time for you to go across the hall and film and be interviewed if you want to. We can take a few questions, maybe like 3. I'm going to say 2 or 3 because we only have the room for so many times. So if you have a question, instead of writing it down, just raise your hand. Yeah. How do you help your significant others understand what lupus is? Do you want to answer that?
Yeah, Al has a really good analogy, but I think, have you looked at the spoon theory to have them understand? I mean, that's one part of it, but Al has a really good analogy.
You know, I'm the analogy. Which one? Like, which one? Which analogy?
The fighting.
Oh, yes. Thank you. I don't know what I would do. That's that lupus. So one of the things that I had to do with my husband, although we have been married for 13 and a half years, at the 2011 when I was sick, although we had been married for quite some time, and of course he's seen me go through some things with lupus, that was the worst that it had been, and he was just in denial. Like, he just did not think it was as serious as it was. And I had to explain to him, and I often use this analogy in talks, is when you're talking to someone who doesn't get it, the best way to explain it to them is like thinking about being in the Army, and you're at war, and you have your front linemen who are supposed to protect the rest of the battalion, right, when the enemy comes. But instead, when the enemy shows up, the front line doesn't fight against the enemy. It turns around and fights who? Everybody in the battalion, and starts taking them out one by one. That's what lupus does to our body when an infection, we have some type of something going on in our system. Our immune system is designed to fight the enemy. But in people who have autoimmune diseases, especially lupus, our immune system does the opposite. It turns on us and attacks us. And so I had to get really honest with my husband about what I was feeling. So storytelling is not just some cute little term to go out into the public and share with the public. It really starts at home with your loved ones. Even my mom, I wish she was here today, but she, from a mother's perspective, shared how when I first called her and told her about my diagnosis, she did much of what I did, and that was just to go into denial. It's a it's a mechanism, a defense mechanism. Like, that's what we do.
And to some extent, there's a little feedback here. And to some extent, I don't think anyone can really understand what someone else is going through. So I think it's a matter of accepting that your support system may not understand, and just communicating what you need from them.
I also want to chime in also, is that, in our support groups, we welcome the caregiver. And actually, I've heard from a few people today. So first of all, the Mata sisters are a perfect example. One has lupus, the other doesn't. They co-facilitate the group in Baldwin Park. I was so close. I am very geographically challenged, and I'm sorry for that. Without GPS, I'd be always lost. So I would say two things. I would say bring them to a support group. I would say also, just as you build your doctor team, you all have a lot of ISs, right? You have your rheumatologist, your cardiologist, your dermatologist, your nephrologist, your whatever, your psychiatrist. You have a lot of ISs. And I would say it's just as important to build your team with supportive people who may not be your spouse. And then another thing that I want to say is, I've heard from a few people today about the need for maybe a support group for the support, which I think is a super interesting idea. And, every now and then someone brings that up, and we've heard a couple of different support group ideas today, and we always welcome them. However, what I want to say is, the Lupus LA team is a small but mighty team. And we love new ideas, and I will work super hard to try to find the funding for those new ideas. But it's really important that if you have a new idea, that you are also an active part of the solution and trying to make that happen. So if that's something that you want to do, if you live out in Thousand Oaks, or you live out in Santa Barbara, or you live in St. Louis Obispo, where we don't have support groups readily available, or you live in San Diego, and that's something that you want to talk to us about, we welcome you to talk with us about it, but we're also going to ask for your help and involvement in making that happen. So those are some suggestions. But really think about building your team and expanding your team, because no one person, whether they're your spouse or your parent or whoever, can really fill every need that you have just as a person. And you've got to sort of think about your health and your care in a more holistic way. Not holistic like earthy crunchy holistic, but holistic as in more complete.
I think it's also important, just on the most basic level, is to understand that every day we need grace ourselves, right? We all need grace in our life. So as frustrating as it can can feel, we still have to extend grace to our loved ones who are not showing up in the way that we feel they should be, because the reality is they're just as scared as we are. And we all have our own way of dealing with things. And so just extending that grace, and like Toby said, just building a team around you. And sometimes that team is not going to be your immediate family. Sometimes it's going to be, these ladies are my sisters, and we've become family over the years. And it's because we've just shown up for each other. And so.
I think, did you have a question? Yeah. I'm sorry, the Well Spouse Association. I've never even heard of that. The Well Spouse Association. How many of you have heard of this? No patients allowed. Right. That's fine. Well, first of all, thank you so much for being here. And I love hearing about new things, and I'm totally checking that out because I have never heard of that before. So thank you. Okay, wonderful. Anyone have any other questions? We're running out of time, so hold the applause. I'm trying to get more questions in, but it's awesome that you're clapping. Any other questions? Yes. Thank you so much. Thank you so much for sharing that. All right, last. Oh, thank you. And last question. Going?
Nope.
You have totally made my day. I don't know who you are, but I love you. Thank you so much.
Epic way to end, right?
This has been my most favorite conference. Every time I say that, but this really is my most favorite conference. So listen, thank you so much, ladies. You're amazing. I'm going to say a couple of short, quick announcements. The first is if you have translation equipment, please, and I know I'm sorry it didn't work, please return it anyway. I promise we're going to get a refund. We're not paying for that. The second thing is that in your folders are green, you all have them out. Good job. Fill them out because we read them. We read every single one of them. We take your suggestions for topics. And we love hearing from you. You don't have to put your name on it. It's completely anonymous. The last thing I want to say is there's an amazing movie out called Heal. It is a documentary about the power of the body to heal itself. It is an extraordinary documentary. We have just been given the right by the filmmakers to show this movie gratis for free at every support group, and we will try to show it at every support group in January, February. I'm going to try to do the rounds. So if you haven't seen this movie yet, you can come to a support group, or you can also download it or rent it, not for free, on iTunes. Lastly, parking. Your parking validation. Take it down, go outside, take the elevators downstairs, one floor. There's going to be a massively long line because you're all going to leave at the same time, but I promise you'll get your car and it'll be free. Thank you did Catherine, I forget anything? That was it. All right. Thank you so much for being here today. This is one of the things I'm most proud of that Lupus LA does. And the next one is going to be in March in Loma Linda. It's going to be a weekday. I have no idea when, but we'll let you know. And then the Irvine Patient Conference is June 3rd, 6th, 9th, June 9th. Do you have a question? Each conference is different. We always have a latest on lupus keynote speaker, but we try to have different topics and different doctors at each one. So I would say come to them all if you can, and if you can't, then we do eventually, it takes us a little bit of time, throw up some video on our website. I think on our YouTube page or somewhere. Yeah, on our website. And we will also let you know when a Cup of Tea TV is up and running so that y'all can check it out. Any more questions? Have an awesome day. Thank you so much.